We are starting the live stream on YouTube and yeah, about today's show. We have a special guest co-host. We have Frank Diaz from Chicago area, and we're going to be sharing his story and more. It's Limb Loss Awareness Month, and so we're going to get his story and some others. So make sure you join us and whatever you want to do in the comment section, and we will try to get to them the best we can. We are live on the radio as well. Say hello, Colin. This is our special producer. You're going to hear him throughout the show. Say hey, Colin.
Howdy ho, everybody. Hope you're having a wonderful day.
Yeah, so kind of exciting. He's going to be jumping in, and we're going to get started in 3 minutes on the radio. We go live on the social media a little bit earlier, just so we can make sure you're all connected and everyone's ready to go, so you don't miss a thing, because this is going to be a fun conversation. And I'm hoping that, Frank, who is our Dr. John Phillips for the day without the, doctor title, you need a little bit more schooling for that, right? Although, you know what? Colin called me doctor last week, so he upgraded me. He's never getting fired. I'm keeping him around for a while.
Hey, I'm trying to have consistency in life. I appreciate that.
I love that you didn't stutter on it either. I'm not a doctor. I only play one on TV. I'm just kidding.
Hey, man.
Not
That's
even
what you say.
close.
I've seen this show enough to know that you know a little more than some of these doctors say that they do.
Yeah, it's interesting. I went to this event yesterday. I have not been bullied since I was in high school. And there were a couple women at this event, and I've never been, snubbed, catty girls. I'm like, you guys are doctors. Why would you give me the evil eye and deliberately move your chair in a very loud, obnoxious way as far away from me as you can when I want to come sit with you? I mean, we're at a collaborative event. It's like, let's have a conversation if you have an issue with my advocacy, patients, and how things, and you don't agree with my philosophy. But let's have a conversation about it, and let's talk about it like adults. We don't have to agree. We can disagree. We can help patients in our own ways. We all have the best intention at heart. And I was actually almost in tears at this event yesterday.
Oh, we don't like to hear
I
that. I do need to interject real quick. We got a little less than a minute before we air, everybody. Also, main thing I want to let everyone know right now, importantly, is that today is a good day. Today is a beautiful day. And
Yep.
today is a day where I get to see some people that I don't get to see often. So I'm happy that I'm getting to do this with y'all. Right now, we got about 20 seconds till we air. So let's get this firing and going.
But overall, I have to say it was one of the most powerful events, where 99.9% of everyone was so inspiring, so inclusive, gave me so much hope for the future, that there are so many different doctors out there and federal regulators that want to do what's right for patients. And that was the most.
All right, everybody. 5 seconds till we air.
So powerful.
Sponsored by The Way to My Heart Incorporated.
Is Dr. John there?
Sadly, he is not right now.
Welcome to the Heart of Innovation. 60 minutes that could save life and limb, with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by patient advocacy group thewaytomyheart.org in partnership with Abbott. Here are your hosts for the Heart of Innovation, Emmy award-winning journalist and founder of The Way to My Heart, Kim McNicholas, and interventional cardiologist and founder of the Save My Piggies Health Education Series, Dr. John Phillips.
Hi, everyone, and welcome to the show. It is Limb Loss Awareness Month, and that's what we're going to be focusing on in today's broadcast. We have a couple of different stories of folks who are thriving with their amputations due to a disease known as peripheral artery disease. We talk about it a lot on this show. It's a debilitating disorder that is more prevalent and deadlier than all cancers combined. But if caught early and diagnosed early, and the patients are allowed to start on conservative treatment, lifestyle modifications, walking, exercise, maybe a few medicines, disease never to a point where their leg is on the line, their limb is on the line. But sadly, this does not rear its ugly head. And the first indication you get is this wound on your toe, or that won't heal, or your leg goes cold. And it's really, really hard. So, um, you end up with an amputation. But it looks like we have Dr. John Phillips, who is joining us live from a cadaver lab down in
Hey.
San Diego. And I want to introduce, though, John, my
Yes,
co-host for the
yes, yes.
day, who is Frank Diaz, who is joining. He's a guest co-host for the day. Say hi, Frank.
Hello, good greetings from Chicago. Hello, Dr. John. Hello, Kim.
Hello, hello, hello. Can you guys hear me okay? It's very
Oh, we
loud
can
in
hear
here.
you and everyone else who's learning in the background. Tell us what's going on down there.
Yeah, so this is a fantastic course that is sponsored by Philip for
No
patients.
relation, and only
No,
one L
yeah,
versus
yeah,
two.
exactly. 1L versus 2 for patients for physicians who are trying to learn more about critical limb ischemia and treatment options. And so Philips, the company, has multiple devices that we are able to use to help get better blood flow for these patients. And basically, yesterday we were kind of going over the devices outside the cadaver lab. And today, now we're using the devices under ultrasound and fluoroscopy. And it is so loud. There's a laser that they're using. There are little mini stents that we're going to deploy. They have an ultrasound machine that we use so we can see inside the artery. And basically, this is just it adds to our kind of toolbox for us to see the vessel, treat it appropriately, get better blood flow, and then hopefully preserve the limb and save the piggies.
I think it's interesting for people, who are patients of PAD, to learn that doctors are always learning. They're still learning throughout their career.
Yeah, 100%. We have probably 15 to 18 participants. There's 4 of us on faculty, and it's a very collegial environment. We're all sharing kind of our tips and tricks. And we just before we went to the cadaver lab, we were talking about complications and how to manage them. And so we're really just trying to continue to push the envelope, so to speak, and train as many folks as we can to treat patients who have limb-threatening ischemia. I know, Kim, you had mentioned in the intro, the mortality rate is horrific in these patients. Lung cancer is worse, stomach, esophagus, pancreatic. That's about it when you're talking about worse mortalities than CLI. And so we've got to be better at treating this and having people live longer with all their piggies attached to them.
And that's, it gives us so much hope. This is Limb Loss Awareness Month. And so knowing that there's doctors like you, and you said there's 15 to 18 others that are down there, and they're trying to learn new tools, new techniques, any way they can to try and keep people's legs attached to them for as long as they can.
100%. And, we have to thank industry for sponsoring these. And then I always thank you, Kim, for sponsoring the patient side of things, because it truly takes a village to treat these patients and take care of these folks.
That's amazing. Thank you so much, for jumping in and sharing. I know you have to get back to teaching and training the next generation of advanced limb savers, whom we call CLI fighters. I mentioned the limb loss stage of this disease is CLI, critical limb ischemia. But John, before you go, I think Frank is filling in for you, so I think he wants to share his moment of inspiration with you.
Thanks, Frank.
Dr. John Phillips' spectacular vascular moment of inspiration.
Thanks
You're off
very
and
much,
running, Frank.
Doctor. Thanks very much. I appreciate it. Well, my quote for the week is, "In the middle of difficulty lies opportunity." And I believe it was attributed to Albert Einstein. And my moment of difficulty happened when once I already submitted to the amputation and gave up my right leg below the knee. I had to decide what to do with my guitar playing. I play guitar in a band. I've been at it for about 17 years now. And I certainly determined that I did not want to play sitting down. My mission, my objective was to play standing up. And with the help of my prosthetic and very good therapy, I found opportunity in the middle of that difficulty. And that certainly became my motivation to not sit around and wear the prosthetic and not do anything with it, but to certainly keep it going. And to this day, I prefer and I do play guitar standing up.
I love it. John, what do you
Fantastic.
think?
I love it. I love it. I love the fact that you did not succumb to the illness, and it doesn't define who you are, because we're all individual, and put one foot in front of the other, one prosthesis in front of the other, and keep walking. I love it, guys. I will try to jump back on if possible, but we've got to get back to lasering.
No worries. We're going to get to more of Frank's stories. You get back to training all of those doctors to save our piggies. We'll be right back with more of the Heart of Innovation and hear more of Frank's stories. So stay with us right here on 860 AM, The Answer.
Leg health can indicate.
All right, you're clear on that side.
Okay. Frank, was that fun?
Yeah, the juices are flowing, just like my radio days back in the last century, in the 80s.
Hey, you want to take us, do you want me to take us back in on this one? And then you can try and take us back in on the next couple? Since this is on your story, I was going to let you take it back in, but I'm like, maybe it's kind of weird. I should take it back in on this one. And then when we go to Christine's story, maybe you can take it back in and introduce Christine if she gets on.
Okay. Yes. Let's do that in that fashion. Please take care of setting up the next segment, and I'll do the same later. I'll be ready for that too.
Awesome. It's fun, huh?
It is.
Great.
I actually got to sub.
Heads up, everyone. Just to let you know, we got a minute till we air, okay?
I got to sub for a Sunday DJ locally, and it was like riding a bike. I got so excited, and it was a one time, but it's nice to know, it still gets the cardio going.
I love it. Josh, we're going to try and see if we can convince Frank to do some Spanish interviews with doctors and such for us.
Yes. Let's go. Let's follow through with that.
I like that. I like that a lot.
With the time,
it's not only a very different perspective from the patient, but it's also, he has, broadcast experience too. So I think it'll be really powerful.
All right, heads up, 7 Up. We got 10 seconds till we air.
Heads up, 7 Up. How about heads up, Dr. Pepper?
How
about heads up, bacon? Right, Douglas? Heads up, bacon.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone, and welcome back to the show. Dr. John Phillips is on assignment teaching other doctors to save our piggies down in San Diego at a Phillips Healthcare event where doctors are actually training on some newer devices, newer tools, newer techniques for limb salvage for a disease that is more prevalent and deadlier than all cancers combined. It's called peripheral artery disease. In advanced stages, it's known as critical limb ischemia. Doesn't have to advance to that stage. If caught early, lifestyle modifications in medicine can be enough to stall progression, and that's really what's key. But if it does get to advanced stages where the arteries and the legs get really blocked, there are some newer tools and techniques that are available now, which were not available possibly back, when Frank was having trouble, to actually get all the way down into the calf, into the foot, if medically appropriate, to try to save the piggies. But Frank, you're co-hosting with me today. Well, Dr. Phillips is on assignment, but also along the way, we want to hear your story before we have another guest joining us later on, Chris, and she is going to be calling in from Georgia to share her limb loss story for Limb Loss Awareness Month. So thanks for being here. You used to be in the radio business yourself, right? So this is like old hat for you.
Thank you, Kim, for the chance to co-host today. Yes, actually, I spent 6 years, 6.5 years in radio news in Spanish, in Espanol.
Oh, wow.
And I also transitioned from news to sports. So I have a broadcast experience, even though it goes back to the previous century. It's been a while.
When you experienced peripheral artery disease, was that when you were still on the radio, or did this come later?
This happened later in my second chapter. I had left radio news to join the marketing world and work for local nonprofits. And I was actually involved in a lot of health outreach fairs and community affairs involving these local organizations.
Oh, wow. How ironic is that? You're sitting here, you're focusing on healthcare. You were feeling healthy at that point. And then what happened? When did things change for you?
Well, the backstory is that I've lived with diabetes for many years. I was diagnosed for diabetes in my 20s.
Type
So
1 or
it
type
was,
2?
it was type 1 at the time. Eventually, it became insulin dependent. But
Yeah.
after I first was diagnosed with diabetes, I was thinking that I was taking care of it very well. Little did I know that plaque buildup happens anywhere in your body. And in my case, a blood clot built up in my right leg behind my knee. So it was a foot drop, an actual inability to pick up my ankle that first signaled the possibility of PAD. And that happened in a commute. I was driving home from work when I couldn't pick up my foot anymore, so I could work the pedals. And I actually had to get home using my left foot, which if you've ever tried to drive with your opposite leg, is kind of difficult, but I made it safely.
Oh, that must have been, how far did you have to drive, or how long did you have to drive? Because I could only imagine it was almost like slow motion. The world just stops at that point and you're scared. Did you think to drive yourself to the emergency room versus just going home? Or did you just think
Um,
your foot fell asleep?
no, I really didn't realize what was going on. I could tell it was unusual. And at the time, I didn't connect the dots, but I had experienced foot drop on a dance floor. Actually, my wife and I went out dancing, and I realized that I wasn't using my right foot the way I used to.
Wow.
But for some reason, I thought nothing of it until that fateful day in November 2014. It'll soon be 10 years since this clue came before me.
Now, when you were diagnosed with diabetes 1, did they give you any indication of the risks that are involved, even if you do control your blood sugar to the best of your ability?
Yeah, actually, there is the usual list of warning signs and possible after effects of diabetes. But at that time, again, PAD was not on that list. I didn't see the connection that I now understand happens between taking care of diabetes or management of the disease and possible PAD.
And so, at what point did you end up in the emergency room, and take us from that point in terms of your treatment that ultimately, and the timeline that ultimately led to the amputation, or the decision that there was nothing more they could do?
All right. Well, I consider myself pretty fortunate now that so many years later, I understand PAD, and I've heard of so many different stories regarding management of PAD, because I was in my doctor's office taking care of a usual follow-up my primary physician noticed I did not have a foot pulse, and my foot did look a little pale. So he personally and literally walked me from his medical office, a professional building, across to the main hospital, my hospital of record, so that I could get advice from the ER and then identify a vascular surgeon right away. And both my doctor and the vascular surgeon called it. They said, Frank, you have peripheral arterial disease. So, unlike others who don't know, or doctors who don't recognize it or misdiagnose it, I was fortunate enough to at least, call it the right
What it
way.
is.
Call it
Yeah.
what it
And
is.
I'm curious because you mentioned you didn't go to the hospital right away when you couldn't get home or you barely got home with foot drop, couldn't feel your foot. Did the feeling come back and then you said, well, I don't need to go today. It seems okay. I'll just wait a few days and go to my primary care. You didn't go to the emergency room or anything.
I actually didn't run, pardon the pun, I didn't hurry up and get to the ER, but I attempted to put some ointment on it, some of that popular ointments that you use for muscle relief or cramping.
Okay.
And right away, it was fire. It was like my foot was burning. And again, I didn't know what to do with it. But I went to sleep overnight, and then in the morning, I still couldn't move my foot correctly. So that's when my wife and I went to see my doctor hours later. I think it was a Friday. So this was
Now,
an overnight thing, but I
so I would
attempted.
imagine that the vascular surgeon did probably an ultrasound, probably went ahead and did what they call a CT angiogram under fluoroscopy to better visualize your arteries with some contrast fluid. At that point, they told you there was some sort of blockage, some sort of clot up behind your knee. And then did they offer you any sort of bypass or were they able to try bring in a wire and balloon or a clot busting medicine directly into there? Nothing? Anything?
Well, as I recall, the first in a series of ultrasounds might have happened right away, but it's been 10 years and some of the details get fuzzy. But yes, I'm pretty sure my vascular surgeon uh, took a look inside the ultrasound and wanted to go ahead and begin procedures. I must say that I did not know much about limb savers or CLI fighters, so my very first surgeon went the conventional route. First with the stents, then with a bypass, then with whatever was next. Each time he was telling me, if this doesn't work, we'll try this. So that gave me the impression that I was in really good hands, and uh, he had an idea, but little did I know that it was more of a by the book treatment or protocol,
Right.
and
You
that
didn't even think to get a second opinion, different doctors, different tools, different techniques. They could, be the head, of the department. They could have every sort of honor in the world, but are they the right doctor for you? Are they actually keeping up with the advanced tools and techniques? It's always good to get a second, maybe even a third opinion before having any surgical procedure. And we'll hear more about that and Frank's thoughts coming up next, right here on the Heart of Innovation. Stay with us.
3 years ago, my symptoms.
Everyone's clear on that side. Also, Kim, I have Christy on line 1 right now. She's on hold.
Okay, tell her we'll get to her in just a little bit. I want to finish kind of Frank's story, get into Frank, I want to get into the timeline a little bit. How long before each one of these I also want you to be honest of the fact that you don't
Christy,
think
can you hear me right now?
I can or Christine. You're talking to Christine.
You guys are okay? Keep going. I'm just gonna try to talk to her on the phone.
Okay, perfect.
Yeah.
And I'm sure you probably have quite a bit more because I was thinking that we would do 10 more minutes with you. And then what we do is then we'll go into in the next segment. We'll let you jump in with Christine.
Okay.
And let you start that conversation. We'll have 10 minutes with her, 4 minutes with her afterwards. We'll end the show. And then we can continue if we have more with her for a few minutes in the after show. And then I can put it together later for the if we have more that we have to discuss with her. And I can put it together later for the in the reporting.
Okay.
But we'll try and get as far as we can, at least create some sort of some closure at the end of the show, but we can always go more. But it sounds like you're really interesting. I think that even Douglas, was jumping in, and I think you have a really interesting story and you're conveying it really well. So I want to continue with you and then jump in if you don't mind.
Yeah. I'm about to tell you that the whole thing between my first symptoms and amputation lasted about 2 years. So my timeline is about 25 months.
Okay.
Just give everybody a heads up. We have about a minute till we air.
Oh,
Okay.
Okay.
Also, Kim, just wanted to let you know for the email stuff with me, my work email is still doing the stupid stuff, but my personal email did work when you sent me stuff. So if you want to send me stuff in the future, you can go ahead and send it to my personal.
Okay, you don't mind. I don't know what the deal is with they can't fix that work
At this
thing.
point, I just want things to go smoothly with your show, and that's what's making it go smooth. So, yep, send it to me. It's fine.
Okay, then I'll because I'm now just doing because Dr. Phillips doesn't read my notes when I do them, so I stopped doing those grander notes. I was doing those notes mainly for him for the show. And it was nice to have a show sheet, but it was a lot of work to put into that.
Yeah.
And he's just good on the fly.
That is very true. That is very true. All right, everybody, heads up, 7 up. We got about 15, excuse me, heads up, doctors up?
Dr. Pepper.
Dr. Pepper, my fault.
Dr. Pepper's in the house when Dr. Phillips is not.
860 AM, The Answer.
We live in 3.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone. Dr. Phillips is on assignment in San Diego at a Phillips Healthcare training event where he is on faculty training about, I think he said, maybe 15 to 18 doctors in new tools and techniques to save our piggies for peripheral artery disease. And so we have our guest co-host today for Limb Loss Awareness Month. It is Frank Diaz, and he is a former radio announcer. And he also has experienced PAD. He has type 1 diabetes, which is one of the major risk factors for PAD. And he ultimately did end up losing a limb to this disease. And he is walking us through the process. Before the break, Frank, you were telling us that there were a series of procedures that were performed to try and save your leg for as long as they can. You were talking about a minimally invasive procedure known as endovascular, where they place a puncture in a lot of times, most of the time, actually, your groin. They send in wires and balloons to try and push the plaque aside. And then they follow up with a scaffolding known as a stent in order to hopefully maintain that vessel open and keep that plaque that they push to the sides there to the sides as long as they can to maintain that blood flow. But we say it's not a matter of if those stents block up again, it's a matter of when. Ultimately, then they went to a bypass, correct? What did you have, a femoral popliteal bypass where they place a graft? Was it your regular artery or was it a synthetic graft that they were able to use and place in your thigh and reattach below your knee in the vessels below to reroute the blood flow?
I believe it was a FemPop, as they call them for short.
Correct.
I've never been very good with all the medical terms, but
Okay, so
yes,
it
I
was an actual
know.
fem pops. They actually placed the end of the graft behind your knee, just beyond where the blockage was.
Yes,
Okay.
that's right. And it did work, actually, as many of these procedures do. It had a short-term effect. It did allow for blood flow and warmth to return to my leg and my foot, and I was fine for a few months. But then again, a lot of the damage might have already been done. My surgeon, who I commend for his efforts, definitely commend, he continued with a similar second procedure, a duplicate from the groin downward. And then from the stent, we went to the angioplasty and then the bypass. And
Okay.
as I said earlier, he kept encouraging me with a description of what he did. And then he would tell me, if that doesn't work, we'll go to this. And he would describe the next procedure, also short term. To keep it short, 25 months lapsed between my first symptoms, my warning signs, and the eventual amputation in January of 2017.
Did they give you any indication as to why you kept blocking back up? I imagine that if it was blocking back up and especially into the bypass graft, that you had a lot of clotting that kept reoccurring. Did they give you any antiplatelet therapy? There are a couple different types of blood thinners they usually use, anticoagulant therapy and antiplatelets. Did you have any of those that were given to you following any of the procedures to see if they could thin that blood out?
Yes, I was prescribed some anticoagulants.
Mm.
Uh, Apparently, that wasn't the answer because, again, within a few months of taking anticoagulants and following up, uh, the next surgery came, and then the next CT scan would happen uh, to confirm where blood was flowing or was not.
It's
Uh,
interesting because nowadays, what they're looking at is doing, a dual approach, an antiplatelet therapy, and to prevent the platelets from coming in and connecting together, and then, the anticoagulant therapy, together as a dual approach to prevent it. And so, if we see this revolving door of procedures happening, it's really good. Just a note for people that are listening or watching right now to make sure to ask your doctor and always have them readdress what your blood thinning cocktail is to see if there's something that they can do there, a change they can make in order to see if they can make a difference in the thinning of your blood to prevent this from reoccurring over and over again.
Oh yeah, that's a definite. And I just want to say, Kim, at that moment, again, 2015 or so, I just put my complete trust in whatever the surgeon was doing or teaching me. I knew nothing about PAD except very superficially, and I didn't really take advantage of asking for a second opinion or researching even further. And I live in a very busy medical hub. You would think in Chicago I could just pick up the phone and call any medical center and say, I'm looking for a second opinion, not like in any other city or town with one or two hospitals. So it is kind of embarrassing, I guess, to say that I was really flying blind and letting the surgeon make all the decisions. So that's why I go around saying, don't be like me. I'm the don't be like me guy. Be sure to ask, be sure to question everything and find a second opinion somewhere. Definitely.
And why is it? I mean, we have a lot of people who tell me, "Oh no, I'm not going to get a second opinion. I don't want to betray the doctor. I don't want them to not like me." And I like and trust that doctor. So I don't really need one. They work at a big medical facility. They're the head of the department. They have lots of honors behind their name. Why still get a second opinion from your experience?
Well, you got to confirm by some other independent means that you actually have that status, that type of diagnosis. And then also what we've learned now about advancements in procedures and advanced tools and techniques, and the right professional, the right medical expert who can very easily, I wouldn't say easily, very proficiently handle the different methods that, again, are changing quickly. And
And we
thanks
have
to Dr. Phillip again
one of
for
our
doing
viewers
that.
actually just messaged and said, Douglas, who's saying that, you didn't think about getting a second opinion at the time, why you didn't think of getting a second opinion at the time, and then what made you think of this second opinion and wishing you got one later on as 2020 hindsight.
Well, I suppose it's in my nature. I'm somewhat shy, even though I like microphones and I like radio. I
Me too.
I just it didn't occur to me just because of my particular personality, let's say. And so I went into it with no fear. As I look back, and I hear a lot about people being scared and being afraid because PAD is not a well-known diagnosis. However, I just trusted a doctor completely and took the fear element out of it, and didn't pursue any other method except the one coming from my neighborhood hospital. Again, as opposed to going across town or check in with so many hospitals we have here where I live. So I suppose all of those elements put together kept me in that status.
And we only have a few seconds left, but what was really going through your head, through that time, when you finally had to make that decision? Go ahead and amputate.
Well, very quickly, I noticed my foot turning colors, and my doctor told me, "Oh, you'll have a great prosthetic technician in such and such an agency." So he already was thinking ahead to my artificial right leg, of which I'm a proud owner now. Again, that's the way I was coached through it.
Thank you so much, Frank. We'll be back with another PAD warrior sharing space. So stay with us here on the Heart of Innovation. Don't go away.
We all know that aches and
Everybody's clear.
Awesome. So, Frank.
Yeah.
Do you want to say, hey, welcome back? You don't even have to say welcome back to the show. Just say, this segment, we're focusing on Limb Loss Awareness Month. I'm, co-hosting with Kim McNicholas, and we're going to be talking, I've lost my limb due to peripheral artery disease, and we're going to talk to, and we're going to talk to, Chris. Chris, hey, welcome to the show. Whatever question you want to start with to kind of help us get to know her. And then we'll go into
what's Chris's background again? Quickly.
So Chris lives in Georgia, and I don't know her whole history of when she was diagnosed with PAD, how she first found out she had PAD. Was she healthy before? I don't know. Did she have diabetes? I don't know. Did she smoke? I don't know.
All right. So tell us a bit about your PAD experience and how you found out.
Yeah. What was your first indication? And did you have any risk factors for that? Right. Diabetes, former smoker. But what we do is when we cut this later, so that's why I don't want to do welcome back. I already talked about XYZ, started as if it's brand new and fresh.
Okay. All right. Brand new. And, okay. And I think we're about 30 minutes in, right?
Yeah, but we're going to cut this segment separately later. So you can just say, welcome to the Save My Piggies, Limb Loss Awareness Month segment. I am
Heads up, 7 up, 10 seconds till we hear.
All right.
8:60 a.m. Yeah. The answer.
You can rest.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hello again, everyone. Welcome back. I'm Frank Diaz, your guest co-host for this segment. Thanks to Kim McNicholas for inviting me in. And now we're going to be talking to Christine regarding her story and her experience with PAD. Hello, Christine from Georgia.
Hello.
Yes. Thanks very much for joining us. We'd like to know more about how you came across peripheral arterial disease and what has it meant to you at this point?
Well, what happened to me was that I caught COVID in December of 2021, and I took the experimental antibody shot that they had at the time. And 2 days later, I woke up on Christmas Eve in the hospital with my left calf just open, and they told me that I had suffered blood clots all over my body and that my left leg was going to be amputated below the knee, and that I had one in my lung, I had one in my stomach, and an aneurysm in my stomach, in my aorta, and I had them in both legs. So, of course, after that, I got the amputation, and then I was put on blood thinners.
Wow, so this was more of an acute hypercoagulability event. This wasn't a general presentation of PAD. PAD is more defined as atherosclerosis or plaque buildup calcium in the arteries.
Yeah.
And although, acute clotting can present like PAD, it's still restricting blood flow, right? It has that aspect of it. It's restricting blood flow to the foot. So a lot of times we do just consider it and classify it as PAD because a lot of the treatments can be similar. Whether it's using a clot-busting drug or a thrombectomy device, a device that can suck the clot out, or bypass, or in your case, it sounds as though did they go straight to amputation? Or you said your leg was opened up, so it sounds like they may have tried something to get that clot out before you ended up being offered amputation.
I'm not really sure what all. No, I didn't have no chance to be offered any amputation, any choice. They rushed me into emergency surgery. I had just woke up in my apartment and tried to walk and fell right in the floor, and I crawled over and called 911 and unlocked my door. The next thing I know, I wake up with my leg. They couldn't save it. I went into emergency surgery. I know that. And when I did get put on the blood thinners, they did tell me I had atherosclerosis and peripheral artery disease.
Okay.
But I assumed that's the same thing.
But it sounds like you also had on top of that hypercoagulability. Did they find any sort of genetic risk factors for clotting, like what we call, protein S or factor V Leiden? Or what did they just say it was due to the shot or having COVID?
Well, they would
give you any
never
reason?
admit to it being because of the antibody shot. But I'm diabetic, so I had neuropathy already in my legs. And other than that, I don't know exactly what the procedure was. All I know is now, 2 years later, or last year, even 1 year later, the regimen of the blood thinners, the Eliquis twice a day, I don't have any blood clots anymore in my body.
Wow, that's pretty amazing. And you can see, versus with, also, but Frank, are you just now on, because you've also lost a limb and yours is due to diabetes as well. You ended up with peripheral artery disease, lots of clotting that ended up happening. Sounds similar. Are you on Eliquis or Xarelto right now, an anticoagulant only therapy program?
No, at the moment, I do not take those, even though I am.
Okay.
I have been on Xarelto in the past, but right now,
you're stable.
Yes, I've been so for quite a while. Yes, in my
And
case.
so, Christine, though, you're still only a couple years in, and so you're still trying to maintain stability. with your disease?
Yes, I'm still trying to manage my diet and change the way I eat and exercise and everything as much as I can with the amputation. But yeah, I'm trying to reverse what I can or save myself from any more damage.
What was like for you the day before this all transpired? Were you working, living your life, going out with friends and family? Describe what, bring us back to just before this happened and who you were.
Well, before it happened, I was not working. Before this happened, and with COVID, before I got sick with COVID, I actually had been all summer long healing from an amputation on my left foot of my pinky toe. It had been removed in the bone down through the side, so I had just got it healed over summer in October. So I was bound to go back to work in January. The doctor said was going to release me back to work. But then in October I was fine. November I was fine. I was living life, yeah. And then I got sick at the 1st of December, and I was sick for a good 2 weeks before I gave in and went to the hospital. And this was when it was really bad with COVID. The hospitals were packed. They couldn't offer me no steroid treatment because the steroid treatment you can't have as a diabetic unless they monitor you, and they didn't have no room for me. So I was so sick, I would have done anything. I signed the paperwork, and they gave me that shot. And all I remember after that shot is going back home, laying down, and the next thing I remember was crawling to the door, calling 911. And then I woke up with my leg laid open, and they told me about all the blood clots in my body and everything. Funny thing is, though, I woke up, 2 days later for when I was sick as a dog from COVID. And when I woke up 2 days later, my leg was laid open, but my voice was back, my sinuses were clear, and I had no cough from COVID. So it cleared every symptom of COVID out of me, but caused the blood clots in my leg.
Oh.
Wow. I can't comment clinically, on that. We'll have to trust, what you're saying. And of course, that's between, you and your doctors. But we have heard situations where folks have ended up with acute clotting while having COVID. And there was even a young woman I heard who was a model in Florida that ended up with an acute clotting event while she had COVID and ended up losing her leg as well. I want to cut off a little bit early here and go to break, and maybe we'll have an extra minute or two when we come back, because I want to get to the heart of what was going through your mind at the time, if you even had a chance to even process it before you lost your leg, and then what life is like for you right now and the struggles you face. So stay with us right here on the Heart of Innovation. Don't go away.
Alrighty, so she's still on the line. Everything's good. 1 minute till we air, and then yes,
Frank,
you did buy yourself another minute.
Back and process. Hey, we're talking to Chris. Just say, hey, we're talking to Christine before the break. She was sharing she had her leg removed, acute clotting following, COVID. I don't even know if she had the time to even process losing the leg, and then what it was like, what went through her mind, after, and how tough it was to process that. And you could even bring your own thing and be like, I know for me, it was like this. What was it like for you? Because we only have 4 minutes in this segment.
Okay, this is a short segment. All right. Yeah. Let's lead into it.
On that note, heads up, Dr. Pepper, we got about 5 seconds.
This is 860 AM. The Answer.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
April is Limb Loss Awareness Month. Welcome back to the show. We're talking to Christine in Georgia about her story, her case, and all the difficulties that happened in short order. She's only experienced amputation since she survived COVID, but one thing took care of another, and now she's dealing with amputation. Christine, please continue with this experience.
Well, after the amputation, I, of course, had the surgery to heal from. Then I was fitted for a shrinker. And then it took a little while for me to get into a prosthetic because of my insurance wouldn't cover a computer knee. So I went a year in a wheelchair, and then, yeah, it was rough. And when you wake up and realize you're going to lose your leg, I didn't have but 10 days to process that I was fixing to be losing my leg. And, I could tell the way it was laid open, and they wasn't about to save it. But, so it was kind of shocking. I went in one way, came out the other. So, the things I suffered a lot with was depression and the fear of not being able to take care of myself because I don't have children or family that can help me really. But then after a year of a lot of praying and a lot of doctor's visits, a lot of, taking medicine and doing the right, trying to eat right and everything, I finally got the strength up to start doing things. And I do just about everything I need to do in my wheelchair. But now, finally, I got a computer knee for my left above knee prosthetic. And I'm starting to work gait training and walking in it right now with physical therapy.
Yeah, that's interesting because I do recall having some complications having to do with a fasciotomy in which some dead muscle was removed from my leg. And then that was the product of compartment syndrome. I don't know if you're familiar with the term, Christine, but I also had my calf wide open, as you called it, and had to use a wound vac or a machine to clean out my leg for a number of months.
Right, and that
Yes.
was before your amputation because a lot of times, so the pressure builds up. You have so many clots, so many things going on, and it's just like, whoa, no more, no more. Can't deal with it. And when that fails, that's when they ended up having to perform amputation on you, Frank, but also the same thing, right, for you, Christine.
Well, actually, I missed the part. So it was a below the knee amputation.
Oh, for you, it was
and
below
I
knee.
spent the next 6 months getting wound vac in the hospital, or 5.5 months.
Gotcha.
Getting the wound vac in the hospital, and that was so painful. But and then I was released, and I was not even released. I was not even out 4 days, and I fell on my wound, which, mind you, was open still. I was still going to get wound vac done at home, and I lost my knee from falling on it. So I went right back into the hospital with an above-the-knee amputation 4 days after I was released. And so my second amputation was from trauma. I just messed up my whole incision, my whole wound there.
Yeah, we hear that a lot, and some doctors will tell folks that it's better to do an above the knee amputation because they think it'll mitigate that risk of a revolving door of amputations. But we've also had patients with above knee amputations that end up falling and then also fracturing things and causing problems no matter what, because I think that sometimes doctors don't realize, for both Frank and Christine to jump in, but what the struggles really are when you do have an amputation, the physical struggles, right? You get home and then you even forget you don't have a leg, right? And you try to get out of bed, you have to go to the bathroom, you just forget.
Yes, that actually happened to me at the hospital within my 3-week stay post amputation, as well as at home once. And those are the times you don't forget that you don't have a leg. So it's a very common occurrence, I think.
And Christine, you as well?
Yes, I fell twice in the hospital in the middle of the night, trying to get
Wow.
up to the bathroom, completely forgetting. And then the night at the hotel when I had gotten out, when I lost my knee, that's exactly what I did. I got up and tried to stand down with that foot that wasn't not there, and landed right on it. Yeah.
Wow.
You know, and a lot of
Well,
people,
thank you
I think I
so
got
much,
PTSD
Christine, for
or
joining
something.
us. We're out of time here. We're going to end this. It's just really important during Limb Loss Awareness Month to remind everyone of the struggles that people do face when they do lose a limb. Go to padhelp.org if you want to learn more on loss prevention.
Our mission is to help patients live a better quality of life through comprehensive education, real-time support, and high-touch advocacy.
Christine, can we
Everyone's clear on that
for a
side.
few minutes? Do you
waytomyheart.org
mind,
and Abbott.
Colin?
Yes.
Colin, do you mind if we keep Christine around for a few minutes? Did we completely lose Colin?
I think it's muted.
Oh, Colin, you're muted. Let's see if he'll come back just for a second, because I'd like to finish Christine's story, you know, and ask her a few more questions. But I don't think that he is listening. I just messaged him, but it's Limb Loss Awareness Month. We're going to go into the after show. I know Douglas is here as well, and he has quite a few questions. We have some other folks that I see chiming in with questions. Josh, our other producer out there on the line who's monitoring social media, has some questions that are coming in as well. I just wanted to see if we could bring back Christine to get a little bit more of a story. I feel like it was a little bit of a cliffhanger because I know she has so much more to share. Colin, are you back?
I am back.
Would you mind? Did Christine drop off?
No, she did not.
No, I'm here.
Oh, good. Colin, do you mind sticking around for a few minutes just so we can let Christine
Go ahead,
share
do what you
her?
got to do. I'll be here.
Okay, thanks so much. Christine, thank you so much for, you know, continuing this conversation. I know you got cut off a little bit when we were trying to understand your, you know, after you have the amputation, you ended up, what doctors sometimes don't realize is the struggles you have. They think, why delay the inevitable? This is, for you, it was an acute situation and you just had no choice. It was probably life or limb. That point was such a serious clotting disorder with blood clots even going through your lungs at that point following your bout with COVID. But do you want to finish up where I cut you off in terms of the struggles that you were experiencing? Because I heard something that was a little bit concerning to me. Aside from that, was that you went back to a hotel out of the hospital.
Yes. So when I went into the hospital for the first amputation, when I had COVID, the day that I was getting my leg amputated below the knee, I lost my apartment. I lost everything in my apartment. The only thing I had left was my car. And so coming out 5.5 months later out of the hospital, I didn't have anywhere to go. And my local church put me up in a hotel, and that lasted for, after the second amputation, I was a hotel. That was all I could get, you know, as far as housing. And it's been so hard to, because I'm still trying to get Social Security, but I'm also trying to work. But nobody wants to hire you with, you have a, you know, a limb loss. But they call you in for interviews, but they don't hire you. So it's been a struggle for 2 years to even try to get a job. It's just.
And so, Christine, I'm curious because before this bout with COVID, it sounds like you were struggling with peripheral artery disease. Before that, you were in with some blockages in your legs that were leading to your toe amputation, correct? That was months prior.
Yes.
And so, was it during that time and struggle that you ended up having to take too much time off work and not being able to maintain a job?
Yes, I had to actually completely stop working because I couldn't even be weight bearing on it. on the amputation of the toe. We were trying to heal it, but after 3 months it wouldn't heal. So then we had the surgery and took the toe off and the bones and the joint. And then I had it healed. Visually, it was healed, and I didn't have no infection as of October, and then I caught the COVID. Yeah. So I was out of work even almost a year before that, about 10 months before that. Because
What were you doing? What was your job before that, if you don't mind me asking?
I was working in a carpet mill. Down here, we got a lot of carpet mills, and I was working in a carpet mill, just standing in the same spot. The reason I wore the blister on my foot, the ulcer, was because I was doing 12-hour shifts and doing a lot of pivoting on my foot, and the friction, I guess, caused the ulcer. And so I knew I shouldn't be working 12 hours. I shouldn't have been on it that long, but I didn't have no choice because I had to work and it was mandatory.
And did you have any sort of neuropathy? Did you have leg cramps? Were you diagnosed with peripheral artery disease before this, or did they just say that the wound didn't heal because of general diabetic foot, wasn't necessarily your arteries, but it might have just been some of the capillaries, the smaller vessels that weren't getting the blood flow?
They didn't diagnose me with PAD then. It was all about my diabetes and just not healing.
Gotcha. And then it wasn't until you got in the hospital that they said you not only have calcium buildup, but you are exploding with clots.
Yeah, that was after the COVID. So that was that happened within a year span. So in the March is when I got the sore on my foot, and we tried to heal it, and then I had the amputation of the toe, and then it healed. And that was they said that was from diabetes, and then it's like when I took the shot with the COVID, that everything just clotted up, basically in my body. I didn't have any diagnosis of peripheral artery disease, osteosclerosis, when I had the amputation of my toe. It wasn't until after COVID that I had osteosclerosis and PAD.
That they actually told you did?
Yeah. Mm-hmm. Yes.
And I think Frank wanted to jump in there with a question.
Okay.
Just an observation, Kim, regarding all the difficulties, the complications that patients like Christine experience. My story is a little bit different than that. I was very blessed and very fortunate to really have a very understanding wife, very strong family support at the time, and a lot of care regarding that, as well as the hospital staff. A lot of people have trouble once they get in the hospital. That was not the case with me. So I had a lot of good support there as well. And insurance. So many people get tripped up with insurance issues. I was very fortunate as well in that category. So every case is different, and you got to really fight through a lot of these obstacles, as tough as they may seem.
Yeah, I think sometimes socioeconomics actually a lot of times can play a role in, especially when you do have these amputations, how quickly and if at all you can get back on your feet with prosthetics and get the support that you need and get the finances that you need to be able to thrive. And I know, Christine, for you, it's been such a struggle because you haven't been able to work. It's not as though you haven't tried. You've tried to figure out if you could do anything. What kinds of jobs were you trying to apply for? Because you can't be on your feet in a carpet mill, but maybe there's some other skill sets that you have that you could bring to the table where you could be in a prosthetic, where you could be in your wheelchair, and they still wouldn't bring you on.
Yes, I was approved in the program for Georgia Vocational Rehabilitation, and they, of course, help you get jobs with your disability. And so far, I haven't been hired yet, but we just started that in December and then started looking for jobs in January. But I had applied to places like Food City and Lowe's, places that had greeter jobs, and I could with accommodation of a stool, stand at the registers and, check out people, or even work in the garden center, doing anything that I could do. So I haven't had a lot of choices. Also, the Georgia Vocational Rehabilitation has gave me a computer, so I've started doing some training on that, getting my typing speed up, doing Microsoft Office and stuff like that to get skills, so that I could be behind a desk or remote for a job. So they're helping. I just haven't got employed just yet.
I am so proud of you, Christine. I'm surprised though. Did Lowe's give you any reason as to why they would not hire you?
Well, no, they just said that they had filled the position, and underneath it said it's actually said it was not due to my disability. Like they literally told me that I didn't get the job because it wasn't because of my disability or unable to do things that they wanted. That I am able to do the regular things that other people do. Yeah, it was kind of strange to me.
Well, it is because I still see
whatever.
help wanted signs at the ones near us. So maybe you can move out here and then you can work at this one.
Yeah, I mean, so Food City they hire people all the time with disabilities. People, they might have their legs, but they still have other disabilities, and they hire them. Every time I went for an interview, I was like, I'm working on getting my prosthetic because it took a little over a year to get one. And, all I need is a stool. I can shift my weight with a stool. I will be standing, but I'll be able to shift off of my good leg onto the other with just a stool. So literally just my hiney edged up on it. And I could check people out. I should be able to do anything right there. And then, of course, I could move in my wheelchair to another department, whatever else you needed me to do and everything. But it was always that I couldn't perform the full job detail.
Which is, interesting to me. I love the fact that you have so much perseverance. You've always had so much fight, in you. It's why I just love you so much. And I've loved, working with you from the beginning. I've always felt like I've wanted to do more, but this is beyond the realm of my experience. And I know Frank wants to say something here. I'm wondering, Frank, did you have any sort of struggles once you had the amputation with getting back into the workforce?
Actually, by the time I had the first surgery, the one that started it all, I was already 2 years into my most recent job, and that was in marketing and public relations for nonprofits. So I had already let them know that I needed surgery and that I needed time off when eventually I had to give up that job and sadly go on disability. So I haven't been active in the workforce except for music, and that is more of a self opportunity. So my situation isn't so much job hunting as it has been seeking music opportunities. A little different, but certainly difficult to leave the workplace in any case.
And what is it about having this amputation? Did you leave the workplace because of the amputation, or was there a lot more to the story? Because I would imagine with marketing and publishing, it would be something that was more computer work versus, and sitting at a desk versus, having to get out and about and be completely active.
In my case, I guess my job description did include community affairs and outreach, particularly in health fairs and those type of outreach activities. So I wasn't necessarily desk bound, even though I thought for a moment, well, I could at least get to a desk and do some work. And home office wasn't such a big deal as it is now. But yes, I really saw myself in transition, let's say, because of my pre-operation or pre-amputation phase, and then the actual amputation. And again, it didn't take very long for me to do therapy and succeed at a few rounds of home-based, hospital-based therapy, and then the actual prosthetic. which I began using in May, only 5 months after the amputation.
But in terms of that, it's still a very lengthy timeline during that process. Yours was more expedited, you know, you had better insurance and the like, and probably better, you know, financial status. And so you were able to move through. But even with having that expedited timeline of, you know, getting that prosthetic and stuff, you still could not hang on to a regular job because your full-time job at that point needed to be get healthy and get back on your feet again, get used to it, learn to walk. That's a full-time job.
Yeah, exactly. That is the essence of leaving therapy and practicing what you've learned. Getting around the block was such an ordeal, but I found a way to steady myself and practice the basics, as you say. Yeah.
And Christine, this resonates with you as well. I mean, for a long time, you couldn't even hold down a job because of this, because it is a lengthy process. So many doctor's appointments, so many trips, because you had to go from Georgia to Tennessee in order to find the closest place that had the most experience with the right prosthetic for you.
Yes, and thank you for that. We all appreciate everything you do for us. We love you too. I had to go to Tennessee, and then I had to go to Atlanta, and then it was just a lot of doctor's trips back and forth over time. And then like the first prosthetic they gave me that I finally got approved through my insurance was like the manual one, the one that has no kind of technology to it. It has no kind of computer knee or nothing, and I could not walk in it at all. And then this year, just last week actually, a few weeks ago, the Scott Love Foundation, they gave me free of charge a computer knee for my prosthetic, and now I have a knee that works really good. They're looking for me a foot because my insurance just would not approve it. They just would not. For a year and a half, I waited for them to approve a prosthetic, and the only thing they did finally approve was a manual that's so hard to walk in. Anybody that can walk in that thing, I give them props because it is so hard. It's all just manual. And so when I got the computer knee last week, I'm already walking in it, and but I've got a problem with my foot. It's too high, so my hips are off balance. So they're going to look for me a foot. But I already know that when I get it at the right level, I'm going to be able to walk so much better. And the thing is, if they would have just approved a good prosthetic to walk in right out of our surgeries, right out of recovery and healing, then we within 6 to 8 to 10 months you could be right back walking like good. But because time has went by and I had to struggle to get what I've got now to walk in, it's going to be just that much harder to learn it and everything. I mean, I'm going to do it, but it's going to be so much harder. And I just wish the insurance companies would see if they would more people would be able to walk within 1 year if they would just approve the microprocessor knees or the computer knees for them.
Plus, you have a really at that point with great insurance and great disability through that insurance. As you said, since you had that first toe cut off, everything just went downhill. You couldn't work, you couldn't put pressure on it because of the type of job that you had at the carpet mill, and there was just nothing you could do at that point. It was just the timing of it. You end up with COVID in the hospital, and once you got out of the hospital 5 months later, you had to go move into the hotel. But Christine, you've even had time where the social services didn't come through for you, and you were living out of your car even up till just recently.
Yes. There's no help for a 49-year-old with no kids and no, in my town, you have to have children or you have to be in a domestic violence situation, and I'm not. And so there's no shelter here. There's one being built, but there's not one here yet. So yeah, all of that. That's how I ended up in the car, homeless.
And being that person, you're trying to eat healthy, and you're even running out of food stamps. They're not even giving you enough food stamps that you can find this healthy food to improve your diet, improve your prognosis.
To eat healthy is so expensive these days. It's just unreal how much a vegetable costs against a can of soup or a box of something. But yeah, my food stamps get gone in about 2.5 weeks, and that's just with buying, stuff like salads and meat and nothing really extra. But because I don't buy those all those carbs, all those processed foods that cost just $1 here or 98 cents there, the money just doesn't go as far. Whereas I'm paying $1 for a bell pepper or $1 for a cucumber.
Do you have any food banks there or any churches that offer food drives that offer food off to folks who need it?
Yes, they do.
And is that mostly canned food, or do they offer fresh? In some areas, they have programs that offer fresh produce, especially, stuff from stores. They take the stuff from the stores that might have short shelf lives, and on the day they expire, they're able to donate those places.
Yes, I can. There's a Greater Works here in City of Refuge that they send me a box every month of vegetables and meat. Yeah.
Oh, that's fantastic. But it's probably hard because you've been living out of a car. You don't really have an address, and also a hotel, at least until, is there any hope, any plan for getting you into permanent housing with your local government?
I am on the low income housing, but I actually don't have an income right now, and you have to have some sort of income right now. The foundation, when I went and got my knee, the computer knee last week, they've put me into a hotel for 30 days. So I have somewhere to stay right now. Thank you, Lord. And they've been a blessing. And they were talking about a grant they might do to help me get into low income housing for 6 months. So maybe that will go through. But I'm also working with my Social Security lawyer for disability. They're going to they're reviewing it right now, a quality review. So we'll see what that decision is. But that could be 4 to 5, 6 months out.
But you want to work. Now,
yeah.
You want to work, though.
Yes.
And you said that you're in some vocational programs for Microsoft Office as well. And
yeah.
So if anyone's listening right now and has some jobs available, what would you want to be doing right now? What could you be doing? If someone came, hey, Kim, I need to get a hold of Christine. I will hire her. What's a base salary? What are some of the jobs that you can be doing for them and want to be doing?
Well, I could do base salary would be minimum wage. I feel blessed just to have that right there. What I can do is data entry, stuff like that right now on the computer and Microsoft Office and stuff like that. Because I don't have a lot of experience in it, but I'm learning it because I've done physical jobs, and those physical jobs I'm not going to be able to do until I get good with my prosthetic again. So anything that I could do as a receptionist, a greeter job at a store, I really don't know what all I can do, so I get a chance to tell you the truth.
And I want to bring in Lawrence Seller because he is differently abled as well from birth. And he has a show called Abled and On Air where they focus on trying to find resources and talk about resources that are available to folks who are differently abled. And I'm curious his thoughts because his wife is not only differently abled, prior to diabetes and prior to a recent amputation, but they've also, struggled along the way, and he brings a lot of his experience to his show and gives them the ideas for who he needs to have conversations with to help not only themselves, but other people. And I'm curious, Lawrence, from your perspective, your thoughts on Christine's situation where she's differently abled and these jobs are not hiring her. She's gone in. She wants to work at Lowe's. She wants to be a front office receptionist somewhere. they are very clear that they're not hiring her because of her disability, but that, well, the job has been filled. And is this something that you hear a lot? And if so, how do you handle it? How do you help advocate for people like Christine?
Don't forget to open your mic.
Go ahead and unmute, Lawrence. Boy, that was such a good question. Maybe I know his wife is in rehab right now, and so he might have stepped away from the microphone just when I threw to him unexpectedly. You know, I'm always full of surprises, right? And I think he actually just fell off. So he might have tried to unmute and then accidentally dropped off, but hopefully he'll get back to that as well. I want to bring in Alan, though. We'll get back to that question, but Alan has also struggled with the same thing, you know, Christine. He ended up with an amputation and ended up kind of with that same, like, you know, I can't really work. I'm trying to get things together. Thank goodness, you know, he has the family business. And he's even saying today, I think for the first time in the past few weeks, he's been able to, with his prosthetic, be able to get back in the workforce.
Yeah, just got that about 5 weeks ago, and I'm up to about 80 steps now. Just a few days later, and the hardest thing I think is getting used to it and the pressures within the prosthetic. But I'm standing at work now, able to do standing work. I have a stool that I kind of zoom around on with wheels, and unfortunately, I'm faster at what I do now than when I actually had my leg. So that was kind of a downfall.
That you're faster in what you do?
Yeah. Quite a bit faster
so
now.
They're expecting more from you.
Yeah. Well, nah, not really. It's family business. So I just kind of semi-retired. And, you know, I go in when I want, do about 20 hours a week.
Hey, that's pretty good. At least you're getting back. And I think that I love to see that, you know, you've been through so much, you've overcome so much, and, you know, you want to get back. You're young, you want to get back into the swing of things and earn a living. And I want to see if Lawrence has joined us. I think he just tried to join us again. Lawrence, go ahead. I'm not sure if we can hear you. Nope, I think that Lawrence doesn't have any sort of audio, you know, to be able to join. So Lawrence, you're going to have to try again and make sure that you join with either Wi-Fi audio or join via your phone. So I'm thinking that you might have to hang up and try giving us a quick call again. Unless our friend Colin, the producer, wants to give out the other phone number and maybe he can call that. Should I have him call the phone number, Colin?
Hey, I'm still here. Why not? Why not?
Why not? Let Lawrence join the conversation. Hold on, I'll go ahead and get that. Frank, you want to continue for a sec?
Sure. If we're still going, I'm really encouraged by Alan's progress because we have met here in the Chicagoland area, and I even had a chance to visit after his amputation, and we struck up a good fellowship regarding our common needs. So it's good that you've got 20 hours going on, Alan, and I'm sure that will probably be a good stimulation and also good support from your network and your family, if it's a family business, right?
Oh, I've got a fantastic support group from my wife all the way through work and other extended family through Kim, you, Douglas. The emotional aspect of it still gets me a little bit here and there, but I'm working through it, you know.
Good. That's.
Christine has to jump off here, and Christine, we really appreciate
Kim,
you.
can you hear me?
Sharing your Christine.
Kim?
Lawrence on here before you jump, Christine. You know, we do have Lawrence this year. Lawrence, you know, we have Christine, just some quick advice for her or any thoughts she's differently abled now with having an amputation, and you have that show Abled and On Air, and you're all about advocating for people who are differently abled. She's gone on to try and get a job at, for example, Lowe's and a couple of other places to either work a register or to be a front office or to be a secretary. And every single time afterwards, they always tell her directly, oh, this has nothing to do with your disability, nothing to do with that you're differently abled now. We just have filled the position. How many times have you heard that? And what is your best advice?
Okay. First of all, hello everybody. I've heard that numerous times, and Christine, are you there? I'm gonna give you two pieces of advice. Number one, no should never be in anybody's vocabulary. Basically, just keep going. And the other piece of advice I'm going to give you is, have you ever thought of getting a job in a school of any sort? If you have experience working with kids with special needs, for example, try that. Or because in schools, they let you sit down if you can't stand. A lot of jobs in schools, for example, will give you accommodations. You can start from the bottom, for example. You can start, let's say, they have paraprofessional jobs, or they have any jobs like that, clerical, filing, any jobs of that sort. But always try to find any accommodations that anybody will give you, and never. A lot of these store jobs, like for example, I've had jobs in culinary. With my challenge, well, I'll get to my wife's in a minute, but with my challenge, you know, you don't belong in the kitchen. We can't hire you. You know, those things. So never let someone tell you no, and always try to find, like the vocational rehab, always try to find as much accommodations as you can get for that job. For example, I'm visually impaired, so I carry a magnifier with me. I carry my computer that has Zoom text. You know, that's a program for people who are visually impaired. So always try to get accommodations, and don't let no be that person's answer, because when a door shuts, another one opens. Does that pretty much answer your question?
Yeah, so just don't settle for no, even if it might be no somewhere. You know, look for a yes somewhere else. There will be a yes somewhere else. And what I love about your advice on looking in the educational communities, I know a lot of them are looking for a lot of different, even substitute teachers where you don't have to be standing and you're filling in. And I know in the educational systems, they have fantastic insurance and a lot of stability for folks. So that might be a good call for you, Christine.
Yes. And I like the idea of working with kids, especially like any other ones with disabilities or amputations. That would be really good. And I'm going to look into that. I never really thought about it.
Now, one other, if I may, I'm sorry to interrupt. If I may jump in here for a quick minute. You said, I'm gonna give you another piece of advice. Did you say you were homeless?
Yeah. I don't have someone here to give advice.
Okay. If you're homeless at this time, and you said that they're building a shelter, they don't have one yet?
No, they don't have one yet for just women. They've got the domestic violence one, they've got the family crisis one, they've got the drug rehabilitation one, but they don't have just a regular shelter. They have a men's, but they don't have a women's yet.
Now, one thing I'm going to say this: what state are you in, if you don't mind me asking?
Georgia.
Okay. Does your state have a hotel voucher? Okay. I'm in Vermont. My wife and I are in Vermont. Does your state have a hotel voucher program where, for example, if you're disabled, special needs in any way, um, in any way, you in Vermont, if you're a regular person, they give you, well, I mean, everybody's normal, but what's normal these days, right? Everybody gives you 30 days, but if you're disabled, it's against the law to throw somebody out of a hotel, without giving them like 60 days or even 90 days. So you can get an if you can get an extended hotel voucher that, say, okay, I have an amputation. If you do, then they can't throw you out. So, that's just another piece of advice. Does your state have an economic services office?
They have
Food
a
stamps.
development center.
Oh, can you repeat that again, please?
A community development center, and they housed me for about a year and a half before they evicted me because I didn't have payment. They was waiting for me to get my Social Security approved or to go to work. But of course, nobody would hire me, and then I haven't got my Social Security approved or my disability. So I was evicted from them after a year and a half. So they did have housing for me for a year and a half, and I thank God for that. But now,
well,
they
and in terms of your in terms of your Social Security, I know I'm going through the same thing with my wife now. You have to be on top of these things, okay? My wife was hospitalized for quite a while before, during her amputation, before she got into rehab. And I want you to do two things. I would like you to find any grants that you can, look, grants are free money. You don't have to pay that back. Find any grants that might, housing grants, any agency in Georgia that could get you, that could turn around and get you free rent for you can get the first month's rent. And I know in Vermont you can get first month's rent and security, and you don't have to pay that back from any organization that gives that to you. And then you can go get an apartment for cheap rent. Usually low income, but find any grant that can do that. And then also because there's lots of money out there, you just have to search. I know it's
hard,
it's
isn't it?
hard. I know it's hard, and it's very frustrating, and sometimes I want to pull my hair out. I have no hair, but and you want to pull your hair out, but you just have to do the best you can and put a spreadsheet together with all these organizations and just check it off. And then, okay, I did this, now I move on to this. Don't give up, because that's the easy way out. I know it's
that's really good advice.
Go
And
ahead.
especially Christine, you're working on learning that Microsoft Office. So get out that Excel spreadsheet with it a little bit. And so she is in the Georgia Vocational Rehabilitation Program, which is fantastic. And so Douglas had sent that to me to give to Christine's list for sending that as well. And Christine, keep us updated on anything. And if anyone has any work for Christine in, Dalton, Georgia, go ahead and give us a call and we'll put you in touch, because she is certainly a go-getter, has a wonderful heart, incredibly intelligent, and very creative. Thank you so much, Christine.
I also added the number.
Oh, thank you so much, Douglas, for adding the number for that as well. And Lawrence, do you want to go ahead and share as well? I'll open it up now to anyone who wants to share and take the conversation where you'd like it. Maybe Frank wants to jump in and even ask, Lawrence some questions, or Douglas. Go ahead, and everyone, let's have a grander discussion about this.
Anybody want to ask questions? Oh, yeah.
here in the big city, all kinds of resources are always available, both at the city level as well as the state. And even though I personally have not have to rely on those types of resources, I'm glad that Christine, for example, isn't giving up and continues to pursue them in any way possible. And so I would also urge listeners to follow Lawrence's advice and just not give up and keep calling and writing and searching for the next opportunity. Right, Lawrence?
Especially, yeah, excuse me for interrupting, especially for Social Security, because those folks, sometimes you can call and they don't pick up, and there's answering machine after answering machine and after answering machine. It gets very frustrating, and you just have to keep on. The worst thing you can do is get frustrated with that. So if you keep on leaving messages, one thing I'm going to suggest for anybody, not just Christine, but anybody that's dealing with things like Social Security, food stamps, and red tape or bureaucracy, go above and beyond. What I mean by that is there's got to be someone above that other person, another supervisor, a commissioner, so on and so forth.
Right, Lawrence, and that, it becomes like, in a sense, dialing for dollars. When Christine first told me she was living in her car a few weeks ago, I was trying so hard to help her, and I was just transferred, then hung up on, and I never could get anyone to call me back. I was leaving voicemails. For people that are struggling, I think that there should, in every single community, be someone who answers the phone. I know it can be overwhelming, but people need urgent help. And the only urgent help that I could find that was available is if there was a child in a life-threatening situation. That's where I could get a person.
Yeah.
And I won't call those numbers and waste their time to try to get to someone else, because I might, end up preventing someone else who is actually in need from getting through at that time. So I continued my search. And then I was thinking, okay, well, what do I call? The mayor's office. Then you try to call the mayor's office. And then it's just like, again, the complete phone circus. Hit 1, hit 2, hit 3, then you hit 4.
It's like, phone circus. It feels like you're right. It feels like Barnum and Bailey circus. It's to no avail. No one's picking up the phone, and it's just mind-boggling. What do they have? One person running a whole entire office. So you just can't give up in that way. Yeah.
No, and I wish that there was something that they could do. I wish there were some, federal bills that would go through that would make it so much easier. I know that I think Alan was in the situation. Frank already went through it, trying to get disability, at least for people who are, if there's an amputation, there should be some sort of instant disability for a certain amount of time. And I actually think that it should be instant disability for a year. And I'm not afraid to say that, because in the time that it takes for someone to go through the wound healing, then once you finally ultimately get that wound healed, which takes, right, all of you, it takes a long time. You got to then go through rehab. Then you have to go through the process of getting that prosthetic to fit. If you're one of those that is not advanced, it has no give to it, it's difficult to walk. You end up compensating with your other leg, which is also diseased and already hard to walk with. And so you don't use it, and you end up sitting in a wheelchair, and the disease again continues to progress in the other leg because you're sedentary. So it's just like this vicious cycle that's leading to almost permanent disability, because these patients are not getting the care they need sooner rather than later. There's no consistent process across the country, especially when it comes to people who are on the lower socioeconomic spectrum, to expedite the process of wound healing, rehab, and getting a prosthetic that actually works for you. And for Christine, it ultimately took a foundation to be able to get her a computerized knee and an advanced prosthetic that she's able to now look at her. She's not late. She's getting out and she's walking. She's ready and willing to work. But this is now. And I think that it would help so much and give patients so much more peace of mind if they knew that they could get this instant disability in the beginning, get them through the time, to get through the process of healing and getting, back on their feet. And it would have been so much easier for her if she didn't have to live out of her car and worry about where she's going to sleep that next night.
And one last thing in terms of Social Security, with Social Security, the problem is there's a stupid rule, and the stupid rule is if you're prosthetic, if you whatever arm, leg, whatever you have a prosthetic, if for example leg, if you can walk on it. I mean, like, for example, my wife, she can walk on it, but she still needs a wheelchair and she needs certain things. You might be denied if you can, if that leg can have you walk well or something. That's the way they put it. It's not always well. You start out in steps. So yeah, if there was an instant Social Security thing for amputees, automatically, then yeah, they should get Social Security for a year.
Yeah, if you don't have it through your own insurance, that would help a lot. That probably would have helped even with Alan.
Yeah. But grant programs such as long-term Medicaid here in Vermont, for example, those who have long-term insurance, you can get prosthetics almost instant. Beginning prosthetics start anywhere between $30,000 to $35,000 for the first prosthetic. Because I know every 3 years, from the research that I've done and the people I've spoken to, including you, Kim, every 3 years or so, you have to get a new one or get adjustments or, that kind of thing. So if you don't have insurance, you're paying out of pocket.
Yeah, that's definitely true. And Lawrence, while you're on, I know that you mentioned that you are going through this with your wife as well. I'm assuming that, being someone who is a caregiver, being that partner in crime, and watching your wife go through this has been quite a struggle.
You say that with such, you partner in crime. You say that with such, it sounds, partner in crime. Yeah, but go ahead. What were you saying? Go ahead. What were you saying?
Well, I was wondering about your experience, as being someone who is watching your wife through an amputation and your perspective.
Well, being a caregiver, now that you mentioned it, there were days, now mind you, when this first began, and I'll make it short and to the point. When this first began, I was very scared, and I had no choice but to call 911. My wife did not want to go to the hospital. She did not want to listen to a doctor. She did not want to take her medication. I mean, this was getting very serious. She was becoming lethargic. Her numbers, which I won't mention on the show, but her numbers went way up, and that kind of thing. So I had no choice but to call 911, and if it wasn't for family telling me, okay, give Kim a call, uh, basically, Kim, you brought me down to earth, and I got to advocating for my wife and in the right way with those surgeons, and I got to know what to do and how to do it. Because as an advocate, and even as a medical advocate, you have to basically have your notebook, and myself being a journalist, have that notebook with you, get business cards, speak to people, speak to organizations, and get things going. And my wife's been doing wonderful, but it was scary. I'm going to tell you, it's not easy being a caregiver, but now this rehab has done an exceptional job. But as an advocate, you have to basically be on top of things. And if you're not on top of things, it'll get, as they say, hairy again. And you don't want it. And you don't want it to the point where, it gets, it gets where, you don't know what's happening, or, that kind of thing, but you always have to be on top of stuff.
And it's been a struggle for you because you've had to make some really hard decisions and even, fight your wife along the way, as we all do. I have to fight. I even know with my dad, I'm sure Frank will admit that his wife had to fight him a couple times with a little stubbornness. We all have that little stubbornness, right? Along the way when we're going through something. Did you ever feel like, and I know this is, I'm going to be a little crass in this question, because I use it for myself. And did you ever feel like a human punching bag and having, the wrath when someone's going through something as extreme as an amputation and the pain and the suffering? It's easy to lash out, and it's hard, I know, on the caregiver. I've been on that end.
I wouldn't call maybe human punching bag is not the word to use, but in a sense, it was like I was hitting my head against the wall. I mean, in layman's terms. I mean, my wife became very stubborn, but when we got those doctors going and telling her, look, you got to go to the hospital, you got to do this because, for example, septic shock and sepsis and gangrene, when your leg or arm, when everything turns black and you have no blood flow, that's gangrene. Sepsis, gangrene, and everything, 72 hours, or a little bit more than that, but she would have been gone. And I'm glad that I had no choice. We, 6:15 in the morning, we got the paramedic and we got her to the hospital.
Yeah, but you had to fight her. She was not very happy with you for calling 911.
No, she wasn't. Like I was hitting my head against the wall, but I'm not hitting my head against the wall anymore.
No, you were feeling pretty guilty about it. You asked me quite a few times, did I make the right decision? I know my wife is upset with me. I didn't like doing something that she didn't want. It really hurt you. It was pretty just devastating for you having to make that decision. And many times that we talked, you second guessed yourself.
Well, I've learned through my religion, being Jewish, they have a saying, save a life, not take a life. And I had no choice but to save her life. But yes, I was scared. And, human punching bag, hitting your head against the wall, hitting your head against the floor, it wasn't fun because I had to spend about a month and a half in a hotel going back and forth to make sure that my wife's operation went well. So yeah, it wasn't fun. But
how much tougher has it been being differently abled and trying to, both of you, I mean, on both ends, being differently abled and having to go through this? What was the experience like trying to navigate through the already difficult healthcare waters.
Okay. Could you repeat the question again, please?
Sure. How much more difficult do you feel it was? It's already difficult to navigate the healthcare system as someone who has normal, functioning mindset, or what they would consider normal. And as you said, I don't even know what's normal anymore. I don't think any of us are, right? But
Well, everybody in this world globally, there's a lot of disabled, special needs people. So, but everybody has some challenge one way or another. But and everybody's normal. Everybody's normal in every respect. But as far as the healthcare system, I'm going to be completely honest. Coming from an advocate's point of view and a husband's point of view, as well as a journalist's point of view, the system is completely and totally broken. And it's not fair that it is because, example, Israel and other countries have universal universal health care, if I'm saying that correctly. You get pretty much everything for free. It's a socialist, a social society, a social welfare society, if I'm saying that correct. But I work because I want to work. You just have to put your nose to the grindstone and advocate for what you think is right. But the system is completely broken, and you just have to
right. But I think what I'm asking is not about whether or not it costs money. I don't think that that's the issue that you're dealing with. That's covered. What the issue that and there are pros and cons, all over the world. And, sometimes you get what you pay for. And while it can be good, and it's good in a lot of senses, we have people waiting even 2 years in Canada to even see a vascular specialist. In some of those systems. So it really depends. And there are pros and cons for every single health system. And I haven't seen one that works 100% yet. I'm not sure that exists.
But
what I'm asking is money aside, being someone who is differently abled, how tough was it to advocate, for yourself? What were those conversations like with the doctors? Did you ever feel during those situations where they almost were not giving you all of the information? I know you and I talked about this. This is the only reason I bring this up, is because you and I have talked about this, and you have vented quite a bit of frustration with how doctors would talk to you and selectively omit things, not thinking that you would understand.
Yeah, some doctors would basically talk. Some people, and being differently abled, if it's not a doctor, you have to gain, or you have to give respect and gain respect. You can't let people talk down to you, if I'm saying that correct. But like I said, you were there with me 100%, and you talk, and you basically have to align yourself with organizations like yours and other. That's a piece of advice. And other organizations that can help you navigate the healthcare system. Because if you don't know how to navigate the healthcare system, then people are going to, talk down to you. But I knew my wife's medical condition to the point. But what I did was I made sure to have all her health documents in hand. You have to have all your health documents in hand in order to know what you're talking about. But align yourself with the proper organizations to help you. And
it's sad. It's sad that you had that situation, and I knew. When I was at this conference yesterday, one of the things that there was a doctor who had his dad that was debating whether to go to the doctor after a New York Times article came out. And he had to work with his dad to convince him that, hey, if we find the right doctor, you're going to get the care you need, and that kind of thing. And he was able to call a friend of his at another hospital and be able to find a friend in the system that was able to help make his dad feel comfortable and get him the advanced limb saving care that he needed. And I think that you were saying that that is very helpful, finding someone who can help find a friend in the system. Everyone in the healthcare system is there for a reason. Everyone really is there to try their best. And what happens is that in the process, so many people fall through the cracks, and it's not intentional. It's not because they don't care. They're overwhelmed. There's more patients and fewer doctors. But, you know, for me, I was able to call one of the top vascular surgeons in the area who was the head of the department that happened to be on a panel that I was on and I was connected with. I think it was Dr. Alam. And he was able to, how helpful was it to have him come down and to have him coming from more of a friend perspective? I'm your friend in health. Kim asked me personally to come give you a second opinion and sit with you for a few minutes. How helpful was that?
It was extremely helpful because, like I said, when you align yourself, like I was very scared. A lot of people with disabilities, special needs, fall through the cracks. But because sometimes you're high functioning or whatnot. But if you take a breath, because you basically taught me how to breathe, and if you take it easy, because this is going to be a long road, and if you don't de-stress or find a way to de-stress yourself, like going for a walk, like taking time out for yourself, because if you don't take care of yourself, you're no good to your family. And Arlene needed me every step of the way, and I had to take breaks in between. And yes, if it wasn't for family also coming down and helping, I would have been, I don't like saying this word, but I would have been a basket case, if I'm saying that correct.
How hard is it for you as the caregiver to put on a happy face? Because, and I'm curious, even, I know that Douglas has been through so much with a lot of procedures, and Frank, with your amputation, we don't have to continue on just the amputee, route, but it's frustrating as a patient. It's so easy to lose hope. It's so easy to get depressed, but sometimes we, don't think about also those who are around us and love us. And if it's hard on us enough if it's hard enough on us as a patient, imagine also, the pain that the caregiver, your friends, your family feel in terms of hopelessness and having to put on a happy face for you, not in a sense blowing smoke up your skirt and saying, hey, everything's going to be all right, when it's not. But you need that smile, right?
I've got one piece of advice. I've gotten myself, I had to spend 10 hours with my wife in hospital every day. And, when you turned around, told me to take that break, then that's when I did that. But one piece of advice I'm going to tell people: align yourself with counseling, mental health counseling, a psychologist, somebody you can talk to for 40 minutes. There's plenty of 1-800-LIFE-NET is one of those things where you can just speak to somebody on the phone. Those mental health things make quite a bit of difference. But for those that don't have family, align yourself with friends that care, or activities that you enjoy to kind of give yourself a break. Because if you don't give yourself a break, like I said, if you don't take care of yourself, you're no good to your family. And my wife needed me she still needs me. But now that she's in rehab, I've been able to take that break. But being differently abled, in a sense, really, I mean, we're trying to live a normal life. The hardest thing that I'm dealing with is not having her at home
Yeah,
because
that's hard.
because there's a lack. The problem is that there's a lack of home services. I was afraid of her. Okay, is she gonna fall in the house? Is something really gonna really happen where if I'm at work and she's home, what's gonna happen? Is she gonna be able to call 911 herself? So I was very. I mean, we live in. I live a building. I live in a building with some services, but there's not enough. There's not enough home care because home care aides don't want to work. The rehab that she's in now, there's
That's hard.
a lot of traveling. There's a lot of traveling nurses, and that's a problem. There's so
Yeah,
many
and I'm
problems with the
curious
system.
with
Go ahead.
Frank as well. Frank, I know, but I know Frank has to jump off pretty soon, and I know that Lawrence, you were mentioning earlier you have some questions for Frank, but I'm going to ask the first one while you're getting those questions ready for him. But Frank, your experience in being in this rehab and being away from home that long, I'm sure that was also not only hard on you, that was also hard on your wife, I'm sure.
Yes, the extended rehab right after amputation happened in hospital. And so, it was a struggle at first. Again, I had the benefit of good hospital support. And in my case, a lot of things lined up in my favor, but that was quite difficult at first. In total, I ended up with 5 or maybe 6 rounds of rehab and therapy, first in hospital, then at home, and finally as an outpatient. So I had very, very strong support for that. But it's never easy. It never becomes easy for anyone. Before I get going, I just want to say life goes on. And I always like to remind people there is life after PAD. And it's all in the way you choose to overcome obstacles and find your way through them. In my case, music, along with a family, became my big motivation. So after my 9 to 5 was over, I decided to turn my attention to music, band leading, guitar playing, and those were the things that just kept me motivated and kept me going. And so I can say that music went from my weekend thing and my side hustle, as the kids call it nowadays, to my foundation. And so I still to this day like to play standing up rather than sitting down. So I can definitely say that's my cornerstone. That's where my attention goes. And I'm very happy living life after PAD. And again, thanks for the opportunity to participate.
Of
Could
course.
could
And
I
do you
ask you a
mind if
question before you?
Lawrence just asks you a couple questions really quick?
Sure. Hi,
Okay.
Lance.
I just have one main question. I know there's pros and cons to everything, but what was the scariest point in your life when it came to your amputation, if I'm saying that correctly?
I guess the scariest point was the actual decision at the end of 2016. Uh, I was faced with no more bypasses and no more stents and nothing that could keep the arteries open. And as I said earlier, damage to calf muscles was pretty extensive. And so we went through New Year's Eve, I believe, a New Year's Eve party in 2016. And
Hello?
you got to decide, you're going to have to give up the legs. So I went in to my hospital of record with 2 legs, and I came out with 1 leg. as I like to
Mm-hmm.
smile about it now, 9 years later. But
Mm-hmm.
yeah, that was really the scariest point was to
And
actually.
what advice? What? And last question: what advice would you give to anyone? Like, okay, I mean, you gave great advice so far, but I mean, you were. I mean, I'm assuming you were bedridden, so. Uh, I mean, did you start physical therapy right away, or did you have to wait in the bed for that, or did you start right away?
Well,
Saying that.
definitely started right away by doctor's orders. Everyone at the hospital, everyone around me said, don't wait to, don't wait for a green light or anything. Start walking, start stretching, get out of bed, get in out by the hospital hallway with, of course, the help of a nurse. And at first, I was really reluctant. My wife will remind me, I was not too crazy about walking so quickly after the surgery or amputation. But that's exactly
Mm.
what they recommend. And as soon as I mustered up the strength, I was in therapy, walking with the help of the parallel bars, and also, again, stretching with support of a physical therapist. The whole team came together to help me get up and move. And I look back and say, well, good. That's really what's expected of me is not to sit around and feel terrible that I have only one leg, but to actually use what I have to keep circulation going, keep muscle tone, all the physical therapy pluses, all the actual advantages and benefits of moving even with one leg. So
And
yes.
Frank, we're going to keep going. Oh, and one more, Frank, and one more, Frank, but one more, Frank. Um, so
Sorry
I'm
about that.
curious, can you give Lawrence some, just some indication? You're very positive, in your experience and how you were able to move forward, both physically as well as mentally. But there had to have been some moments that some patients have brought to my attention that it can be a little bit of a roller coaster because a loss they describe as being a loss, whether it's the loss of a loved one or a loss of your limb. Can you offer your experience with that grief cycle that you experienced with the loss of your leg and any advice that you have for Lawrence in order to best support his wife through this?
Wow. Well, as positive as it all sounds, yes, it's still difficult even to this day. Uh, Again, my journey has had a lot of fortunate twists and turns. And yeah, there will be difficult times early on. Uh, I guess, using a wheelchair or using a prosthetic device gets pretty difficult. I have to admit, even today, so many years later, I spend a few minutes in the morning staring at my residual. I don't like to use the word stump, I call it residual, and just reaching for the prosthetic and getting the morning started. But once I get through coffee and the usual morning routine, I'm up and moving. So it becomes a very, real but brief moment of reflection on the fact that I depend on a plastic piece of leg to get around. So yeah, so many years later, it's still difficult, and I find it tough to admit. But recalling those days back in 2017, when I had to learn or relearn to do things, uh, it's a big hump. It's definitely a big hump. There's no getting around it. But life goes on, and Pat becomes your companion through the good times and the bad ones. So Lawrence, please let her know there's definitely you know should I say, light at the end of the tunnel.
Yeah, my wife is doing so wonderful with her physical therapy, and she's got a great outlook on life now. But it was tough, yes. But she is doing wonderful, and she's so activity minded because there's activities every day at the rehab. But the toughest thing is, like I said, on my end, is not having her at home. That's the tough part. But I see her at least 3 or 4 days a week, including weekends. But it is tough. But yeah, thank you very much for your advice. I really appreciate it.
Good. I hope we can stay in contact. And sorry, I got to step off, but thank you, Kim, Douglas, and Colin, everybody else.
Thank you. And I'll loop in
Okay.
Douglas. Douglas, I see we had some comments on YouTube that came in.
Unfortunately, I can't see them at this time.
Well, I can. So if you want, I'll do it.
You'll have to read them, but unfortunately, for some reason, I can't read them.
Okay, they're on. So they're in the chat. Josh, our other producer, actually shared them with us. So let me pull those up. We have KGC, and they said, thank you for being there. I'm viewing your videos when I can cope. Coping is always a tough thing. PAD a lot of times has this roller coaster effect, ups and downs all the time, as with any chronic illness. KJC says, thank you. It's a challenge with such, our producer, Josh, responded, coping is important, so stay strong. And KGC says, thank you. It's a challenge with such little contact information and support. I'm in the UK, but don't know where to turn for advice. Are there any PAD groups in the UK that you know of, please? And KJC, I'll also type this into YouTube in just a little bit, but on padhelp.org, padhelp.org, you can go ahead and click on the PAD support groups. And we do have all kinds of different groups that are available. Some are more active than others. Feel free to join them all. Even though the UK one isn't always as active as some of the other groups, we have UK folks across all groups at the moment. But when you jump into and post in the UK group, we also do have a couple of doctors in the UK that are available to answer questions as well. And I believe KGC also had some other, nope, we have another one from Tashna on YouTube as well, who says PAD is an awful disease. There is no support group here in my country, and it's hard on us as a family. Just so sad. PAD, the ankle brachial index test, should be a test routinely done by doctors. And we agree. The ankle brachial index test, in which Tashna was referencing, is where they place blood pressure cuffs on your legs and your arms, and they measure the differential to determine if you're getting enough blood flow all the way down to your feet. If you do have diabetes, you might get a false normal. And so if you are having symptoms of neuropathy, any numbness, any leg pain, leg cramps, any tingling, it's important, even if you do get a normal result in the ABI or ankle brachial index, that you do ask your doctor for a leg artery ultrasound just to confirm whether or not you have PAD. That's really important. But also, Tashna, for you, go to padhelp.org, padhelp.org, and there is a tab for support groups. We have all kinds of them. And even if there isn't a specific support group, as you may think in your particular country, we do have patients around the world and in just about every country that is in, that are in quite a few of our different support groups, general support groups as well. And we do have doctors in every country represented that we can help get you the information and guidance that you need.
But it was like with the show today, we heard from one extreme to the other one, didn't we?
Oh, yeah.
I was thinking about, like, with her in the COVID shot. I wonder if she had that, and that's where, you do those family tests to see if it was there, and did the COVID shot just actually awaken all of that stuff and just blow up in her? And then you heard it took what, Frank, 25 months to get to that point. So it's that, how many of us in Allen was the same way? He was somewhere in between there, wasn't there? So not
It's
everybody just wakes up one day, and
no,
it's not like a car accident where you wake up one day and you're in the hospital, and then the
no.
next day you wake up and you're missing a leg because of the accident. This It goes from one extreme to the other, didn't it?
It does, which is why it's so hard, I think, for a lot of the regulators and even the societies to come up with consistent standards, because there is so much variance in the presentation of PAD. And I mentioned earlier that there is this that the real definition of PAD, how it's defined, is by atherosclerosis, that calcium in the arteries that restricts blood flow. But we're now looping, but that can include some clotting as well. And as we age, I don't think there's anyone, you hit 40 and over, I think you end up with some sort of plaque in your body, right? And even in your legs. It's just a matter of whether it ultimately gets to the point where it restricts blood flow and you start feeling the symptoms because of it.
And how about
But
the
if you
mental
have,
health
let
side
me
of it
finish
too?
this thought really
Yeah.
quick. But it's just, there's also that other side with the clotting disorders. And for example, with Deion Sanders, that they have yet to publicly diagnose him with PAD because they're still focused on the fact that he has this hypercoagulability, this tendency to just clot and clot and clot and clot and clot. And that's also what was happening with COVID, is that people would end up in some circumstances. They don't know what was different about one person versus another, except possibly it might have been, in people that had some other underlying condition that they didn't know about, might have been a genetic risk factor for clotting that might have been triggered during the COVID. Who knows? There's still so many questions. So, but at least we know in Christine's case that there was this possible coincidence, possible series of events. We don't know what caused what yet, or if they'll even make a final determination. All we know is that she had COVID, ended up with some sort of event a day after the COVID shot, which she had while she had COVID, and clots went all the way through her body. And so in that instance, as you mentioned, that's a situation where there may not have been time. Their life and limb was on the life and limb was really on the line with her. And so a doctor's in an acute situation like that, where the foot and the leg is just going stone cold and fast, there may not be time to do anything about it except just cut off the leg, or else it's going to be life, not just limb. And that's where every time I try to guide people, I don't give medical advice, and I don't like to say, and there's any definitive treatment, or all the time you have to have this first, then this, then amputation, because that's not always the case. And I've had quite a few situations where someone's called me from the emergency room and has said, Kim, oh my gosh, I want to prevent this amputation. And when I get on the phone with the patient and the doctor, life is on the line. It's got to be the limb. There is absolutely no time. And they unfortunately just have to make the decision to do it without even attempting to open up those arteries, because there are situations where we've even had, patients, clot is a very dangerous thing, and you can't, it's almost like I liken it to our electricity system, and you can't really tell a megawatt, where to go in our electricity and the wires. A megawatt's going to go where a megawatt's going to go. It's just going to fill the lines. It's going to fill the lines. And that's kind of what happens with the clots. The clots don't tell you which direction they're going to go. They can't, there's no one way or another. Clots can happen in the veins. Clots can happen in the arteries. And no one has enough research to be able to say, oh, we know the exact pathway where this clot's going to go, right? And in a situation, you don't want to poke a wire into a very dangerous, unpredictable situation into that artery, because I always say it's like poking the beehive. I said this to a doctor yesterday. I said, yeah, you don't want to just go in and poke the beehive. She had no idea what I was talking about. And I said, Well, I mean, poking the beehive. When you go in and you go in blindly into a situation where it's unpredictable with so much clot happening and you don't really understand the morphology, um, which in a lot of cases you just there's no way to know. You take a wire, you poke the clot, and it literally has a whole bunch of other clots that it sends downstream, and it just trashes your foot. It fills your foot. And then you're in an acute situation. So I call it poking the beehive. And it's hard to mitigate that risk except to just say, you know what? It's not worth jeopardizing your life. It's better to be safe and take your limb. So I do see those circumstances where that is the case, such as in Christine's, versus in, let's say, Frank's, where Frank had a little bit of time. The doctor did try to go in and suction out that clot, put in a stent to try and maintain that vessel open. It didn't work with his anticoagulation therapy. We also discussed that there is some new research that says that if you do have a revolving door where things just seem to keep closing back up with then you might want to readdress the pharmaceutical cocktail and see if you need to add an antiplatelet therapy along with, let's say, a Xarelto or an Eliquis or warfarin or Coumadin or something like that. And if you are an antiplatelet therapy such as clopidogrel, you might want to say, hey, well, why don't we try a different one? But I think patients do need to be their own best advocates. And as Frank said during it, if he was going to do it all over again, he would have asked more questions. He would have gotten a second opinion. He would have found out if there are other options because different doctors, different tools, different techniques. And even though he liked and trusted his doctor, he now wonders if there might have been a different option in a different hospital. No matter how great his doctor was, it just might have been that someone else might have just been able to look at it with a different eye, a different experience. They may have had a similar patient like theirs that they were able to learn from and be able to use those learnings in order to help make you give you a different option. I'm off my soapbox. Was that informational? Was that helpful? Did it make sense?
It made sense. Absolutely.
Okay, good. It was a very Josh is our producer over there on YouTube. If Josh wanted to jump in and he's saying it was really compelling, and I'm just curious, just being from a layman, a civilian of kind of looking in on the PAD war. Just curious, his thoughts. Following this, it was very emotional. It's very hard, right, Josh? To relate to something like that, but yet have so much empathy and appreciation for the courage it takes to go through something like this.
Well, the greater majority of my experience is through the aortic side of things, right? And yeah, so a lot of my clients are they're patients themselves, or they're caregivers that started a foundation. In the case of Rock from the Heart, and the lifelong requirement to have to be monitored and to have to follow up with again a lifetime of medication, a rigorous discipline of your diet and exercise going forward. It's a trial. It's a lifelong trial. And the caregivers that stay, these are angels on earth.
Yeah, it's a lot. And it was interesting to hear Lawrence's perspective, right? Because Lawrence, it's not only hard enough for us, having, in a sense, and we joke about this, none of us are ever really normal, right? We all have our little things, but our challenges. But for someone who is considered differently abled and having even greater challenges on top of that, and then to have to face these same obstacles, and it's even more exacerbated with them. And it was just so touching to hear, what Lawrence and hearing his fight in him and hearing that hope in his voice and the continued continuing to move forward, right? And persevering and just finding ways and not taking no for an answer.
The thing about a caregiver, they're looking at these illnesses as something that is attacking the thing that's most important to them, and they're willing to do whatever it takes, and they don't understand how much energy that takes. And then they come into something called caregiver fatigue, where they start to have a callous ability to give care properly, and they start second guessing themselves.
Yeah.
And so one of the things that he said was, you have to make sure that you're taking care of yourself, because the better you take care of yourself, the better you can take care of your loved one. And that message echoes over and over again in the other communities that I work with.
Someone said something to me at one time, because I've always been known to never take a moment to myself, never stop, never stop. And Douglas always tells me that I need to stop at some point and take a moment for myself as well. So it's always a good reminder. And a long time ago, someone said this to me, because I never took a vacation. I always wanted to just work, work, work. And my executive producer said to me, you can't give 100% of yourself if you're not 100% whole yourself. And not that you're not doing an amazing job. I just fear the day that you end up sick or run down or something, and it's just gonna be this downward spiral. So she said it's better to take a few minutes here and there to meditate, to pray. And I have these prayers that I listen to on YouTube, actually, and I pull up a different one. I kind of leave it to God to say, okay, I'm just going to pull up YouTube randomly and see whatever inspirational video pops up. And I'm able to take a few moments during the day, jump on the elliptical for 5 minutes and just listen to one of those prayers or one of those inspirational videos. Or I just have Douglas throughout the day that sends me really inspirational messages and Kim, go fight, win, go, 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 this. And that helps too.
Another great tool in the toolbox is gratitude. And when I say gratitude, I don't mean the thanking of the nothingness or the vast array of everything. When I talk about gratefulness, I talk about your ability to understand that you're grateful for today. You woke up today. You should be grateful for today. And then the efforts that you put forward for today, those efforts are things to be grateful for as well. And so if you're having a hard day and it's going to take effort and it's going to be a trial to get into the shower, but you get that shower, you get to be grateful for that shower. And it's that feeling, that gratefulness that will lead you to the light.
I saw in an amputation group a couple weeks ago, somebody had posted they were grateful that day for a shoe.
Yep.
In the caretaker part, I know that for 10 years with Alzheimer's and taking care of my mom till the end. So I do understand that. And the hospice nurse kept trying to get me to understand that until I finally got to understand that to be the best caretaker I could be to my mom, I also had to take care of myself. And that is hard sometimes when, mom was a 24-hour-a-day care in the end. And it was me. And Lawrence and I have talked about this a lot. I work with child abuse and forensic services, so I understand we have places here for specific ladies with specific amount of children, and then there are some ladies that get left out of that circus because it is about money and where does that funding come from.
Right.
So that is part of that bureaucracy and misunderstanding about we just can't build a house for everybody. It's kind of crazy thinking that way, but it's the truth. And it's that revolving, and how do we and what you went through with calling, and you do have to call and call and call and bug and bug. And how many times do you call before you get tired of calling and you do give up? Is that what they want you to do? So there is that. In Kim, I was thinking earlier about, so when you talk about how we need to have specific guidelines for doctors, at the end of each one, do they need to put that word, et cetera, et cetera, et cetera? Because everybody is different, aren't they? In every situation, I mean, how do you make a standard guideline for a doctor with PAD when, like you say, I remember when Dr. Walker went through that one time he went through that I woke up later and he goes, I didn't go through there. And it's like, why? He said, because if I had gone through there, I could have busted that vessel. And if I had done that, you would have just bled out on the table. So I had to go the other way. And it's like, oh, okay. So I think Dr. Walker understood what you were saying when you said, don't poke the beehive. Because he said, if I'd gone through there and as good as he is, he goes, if I had poked a hole in that vessel, there's nothing I could have done. You'd have bled to death. So I stopped and I went around the other way.
Yeah. I mean, they could end up, I mean, in that sense, it sounds as though they also have the issue, and especially when they're dealing, I think in that situation, he was up in the abdominal area, which can be very sticky. And that's why we've had several people that have ended up with aortobifemoral bypasses, because not as many people are skilled in advanced endovascular of the aorta. And if you don't have an advanced endovascular doctor that does this regularly and been able to take wires and balloons up there safely, and even more with what's called an intravascular ultrasound, being image guided, getting a little extra camera inside there, a little extra imaging for that 3D image. And beyond that, there's a technology from a company called Avenger that has a device that is able to cut through some of the plaque, especially if it's rock hard plaque, but it's image guided. It has a little camera on there to help guide, because what these doctors are concerned about, especially in the abdominal area, in the aorta or the iliacs, especially going down to your groin a little bit further, is that they might perforate, send a wire through the wall of the vessel. And that could be life-threatening instantly, just like that. You just bleed out. You can't even get in there fast enough to try and cover that up and plug the hole, right? And that is always a major risk. And so an aortobifemoral bypass, that's why a lot of doctors, it's actually really durable. If it's done right, it can actually last 20 to 30 years, I've seen. If you're taking care of yourself, you're on the right medication, you have the lifestyle modifications, you don't have some sort of genetic risk, clotting risk factor that is not under control, or diabetes that's not under control. I mean, if risk factors are not mitigated, it may not last, and usually doesn't last that long. As I think you discovered as well, Douglas, your doctor before your aortobifemoral bypass didn't bother to tell you not to smoke, didn't tell you to eat better, didn't put you on any statin to control cholesterol, didn't tell you to control your diet, didn't tell you to exercise. And all of that kind of came together, and it ended up failing in 6 months. And it was just this revolving door.
Thing. He tried to put stents in. He was going to put stents in, but I think he got to a point where maybe it was going to be too much work, and it was just easier to do the aorta bifemoral, because that's what I think he did with the Axio that he did with me also. And I saw where a lady posted in the group today that she's scheduled to have one in May, and everybody started asking the same questions. Have you got a second opinion? Did they do this? Did they do that? So, I mean, what guidelines are there for those processes, and does it depend on the doctor? Does it depend?
It really depends on the doctor.
skill?
And I always ask the doctor, what are you most comfortable with? And it doesn't mean that you go with that doctor and you go with that option just because that doctor is most comfortable with that procedure. Does it mean it's the best procedure for your presentation of disease? It doesn't. Does it mean it is an option for your presentation of disease? Yes. Is it the best? It really depends on the person. And I always say, ask the doctor, what's your contingency plan when it fails? Because most of these procedures, I don't care who you are, they fail at some point, and there needs to be a contingency plan. And, for your situation, Douglas, the contingency plan after the aortobifemoral bypass failed, where they bypass a blockage in the aorta and reconnect, they put in a graft above the blockage in the aorta, and then they reconnect it below the blockage, usually down aortobifemoral, right? Femoral down there, in the upper leg. But you ended up having to have an axillary femoral bypass, meaning that they bypassed the aorta altogether, went up to your shoulder artery, and then bypassed all of your organs in order to fuel your legs and reconnected that graft down there in your groin. And then told you once that failed, well, now I have no option for you. And that's something that it's your responsibility as the patient to ask, what is the contingency plan at that point? Once that fails, we all know that they do for the most part. And you always have to be prepared for the worst. What if that fails? What is the next step? And that is so important.
So I didn't have an amputation like Frank did, but at the same time, I'm in the same boat that he was in, that Alan was in, that I know a couple other people were in our group, is that I had not met this group yet. I did not know all the stuff that I know now that I should have asked then. And it wasn't until I met you in this group and Kay and all of that, that I got that information, that if I could go back with what I know now, it would be different. It'd be like Dr. Walker told me when the very first time I met him, he said, if you had met me 2 years ago, you would not have had all these procedures, because there are things we could have done that were different before you'd have gotten to those. So how many people in our group do we hear every day come to the group the first time and say, well, I never thought about that. I never thought about it that way. Because when I was going through this stuff, it was just me. I call my brother every now and then, but I didn't have any family or anyone that kind of to help guide me. So I was just in and out. And how many people in our group do we see that way, that don't know those questions to ask then that we know now?
And Douglas, how much does this play a role in it, in making that decision to, in a sense, like for you with your doctor, when you were having that revolving door of treatments going from the stents, then from one bypass to another bypass to another bypass, that you were like, you know what? I'm in pain. I have no blood flow. I have no hope. And at least there's a procedure, whether or not it's going to work, at least there's a procedure scheduled. And if I don't go with that scheduled procedure, or if I can't get something before, like I'll literally have to keep living with this pain. And it's a whole process by which you have to sometimes go to your primary care office again, get a referral to yet another doctor, and then you have to wait to get into that doctor. Sometimes it could be a few months.
That's a simple question. That's a simple question, but it's an easy answer. The doctor that I had here where I'm at, everybody knew him. Everybody said he was the best. So I was stuck in that white coat syndrome at that time. I trusted him, and I kept following what he was telling me to do. Was it really truly that easy? Yeah, I didn't think about it. You're the doctor, you know what you're doing, and I don't. It was that white coat syndrome where I just trusted him. I didn't know any of this.
Right. I mean, he probably had the best reviews I always tell people I get it all the time. Oh, well, my doctor, I can do the research on my own. And that doctor has just great reviews, and look at all of their publications and look at all of their accolades, and look, they're the director of that particular university or large facility. Look, 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 look. But how much in your sense did that play into a positive outcome for you? And what did you learn later, that it wasn't, that you did have other options than what he provided, and you actually had more durable options that got you
And
back on your feet longer?
that's the part where I have I know now where I would like to go back and ask him how many of these conferences, like with Dr. Phillips today, did you attend? But I know now, I did some research, and I know now that in the last 5 or 6 years, he hadn't been to any. He doesn't go to any because, and I heard it once in this group, a doctor told a group of people, I'm God. I know what I'm doing. And nobody questioned me. And nobody did. But now I know some people that work around where he is, and he's a nice guy, but they all think he's arrogant, and nobody questions him about anything. He just does what he does, and everybody moves on. So my question to him would be, did you ever go and try and learn to do this procedure or that procedure? Did you even go and question this one? Or is this the only way you knew how? Now, I have a neighbor across the street. He passed away last year, who had the same procedure I had with the same doctor. He didn't last a year and he passed away. So it's that, in that part of that insanity, Kim, where you have the good doctors, but they don't go out and get the experience that they need to keep growing, like Dr. Phillips was talking about this morning. I mean, he took time out to go learn and move the procedure to save a life further down the line. How many doctors out there do that and continue their education and become more advanced and more advanced? And we talk about this in the group all the time, don't we? The old doctors are the new doctors. Are they teaching all this stuff to the new doctors coming out there today?
Yep.
Are they coming out CLA fighters, or are they just coming out BSs, vascular surgeons, and then they learn everything along the line?
We were talking about this at this conference that I was at for Viva. It was the Vascular Leaders Forum in Washington, D.C. I was very blessed to be a part of it. It was they hand selected the people that are there, that all had open hearts, open minds, and wanting to create the change we all want to see in improving care and collaboration in the PAD field, from vascular medicine to vascular surgeons to interventional radiologists to interventional cardiologists, and getting everyone to work together and stop this turf war, because there aren't enough doctors to go around right now, especially in the small rural communities, the most vulnerable communities where PAD exists and has become a very quick epidemic. And so everyone does need to work together. And a couple of things on that. One, they were saying that, yes, they agree with you that they need to make it a priority to talk to the fellows, whether they're in internal medicine, primary care, endocrinology, whatever other field that could feed into vascular. They need to educate them sooner rather than later about PAD, because an earlier diagnosis makes all of this talk of procedures a moot point. And early diagnosis, medicines, and lifestyle modifications are 90% of the time, they're really effective for people installing that progression. The problem is we're getting to these patients too late, because in our network, we did a survey of more than 400 people, and they reported that despite reporting textbook symptoms to their primary care podiatrist or endocrinologist, despite presenting with textbook symptoms of leg pain, leg cramps, and neuropathy, and even some discoloration, in the first attempt to get some answers, the doctors diagnosed them with something else other than PAD. Nearly 70% of more than 400 people were diagnosed with something else other than PAD, despite their high risk factors, in their first presentation of these textbook symptoms. And the top 5 misdiagnoses include diabetic neuropathy or diabetes, fibromyalgia, back or spinal pain, old age, just old age, and arthritis. And it's not to say that these patients may not have had back issues. I think we all have some sort of degenerative disc disease or sciatica issues as we age. It's not to say that we don't have arthritis as we age, but we need to take a moment, and we need these fellows, we need the next generation of doctors to go in, and even the current generation to go in and just take their hands and feel the foot pulses. And we need a campaign out there to patients as well to say, hey, when you any appointment you go to, you need to take off your socks and present them to your doctor.
So I have a question.
My feet.
So as far as you know, so doctor, just say a doctor goes 12 years of schooling, right? I wonder how many doctors at some point in those 8 to 12 years of schooling did another doctor say, we're going to take shoes and socks off today. Because how many times in this group do we hear, I've been to my primary doctor for 20 years and he's never taken my shoes and socks off to check my feet.
Nope.
You know?
And we hear it all the time.
So
and that's it's such an important thing. And you were referencing as well before about how many doctors, in terms of their training, and how many actually, spend time to stay up to date and stay current, and, and going to these conferences. And one of the important points and that they brought up was the real burnout that our physicians and clinicians are experiencing right now. And if it wasn't bad enough before COVID, COVID accelerated it. And so many more doctors and clinicians retired. We have even more patients than ever with an aging population and a diabetes epidemic. And we have fewer doctors, fewer clinicians. And I'm hearing, for example, with Dr. Walker, he's had up to 100 patients in a day come through his clinic. And while he does have really good support there, he's one of those doctors that doesn't let a patient go into his clinic without walking in and saying hi. Imagine, how much time that it takes and how many hours he's sitting there at the facility. We had another doctor, Dr. Jay Matthews, out of Bradenton, Florida, working at a hospital, and he said he had a 16-hour day the day before because he needed to take Friday off to go to this particular event. He worked a 16-hour day on Thursday in order to do this. Kumar Madasari, we call him Madaz. I'm an interventional radiologist, vascular interventional radiologist out of Rush Hospital in Chicago. And he was there at the event. And I asked him, I said, hey, when did you get in? And he said, I barely got in this morning. I'm barely awake, because I had, I ended up having to do a late procedure. Aaron Armstrong, Dr. Aaron Armstrong, same thing, out of Colorado in the Denver area, literally had gotten in just that morning and had barely gotten there just before the event because he ended up on a late case till like 9 o'clock that night in order to make sure to prioritize his patients, especially the acute ones, and get them done before he ended up having to go out of town. And he was on the red eye coming to this event. So these doctors are working so hard, and it takes so much for them to have to not only do that, but then I know, Dr. Madasari has kids. Dr. John Phillips has kids. Dr. Phillips, not only does he work long hours during the day, he has kids, and he had to travel to go to this training, not just for himself, but he takes the time to train other doctors. And so you can imagine that some of these doctors that are in a smaller town are thinking, you know what, I'm in this smaller town and I'm just going to work my hours. My family's a priority. You understand that, right? Family is a priority. So sometimes, as much as they care about their patients, they do have to draw the line. I was on a plane with a doctor, an oncologist from Australia, and his wife flying to Washington, D.C. And he was like, wow, because I was on the phone with a couple of patients, clear up until takeoff. And he was like, wow, you must be a pretty dedicated doctor. And I said, well, I'm not a doctor. I'm actually an advocate. And he said, yeah, when I'm off the clock, I'm off the clock, and I do not accept any calls from the hospital. I have a team there, and it's just up to them to handle the situation. And I said, oh my gosh, you don't even think about it? He's like, no, I can't, because if I do, I don't have that time to myself to be able to recharge and then give 100% when I am there.
But we
Versus, let's
also have to think, yeah, all right. So here's the thought then. I mean to cut you off, but I want to throw this in there is that thought. Doctors are still human beings also, aren't they? So imagine being a doctor and really thinking about being the best CLI fighter you can. But I have a wife. I have a 14-year-old who loves playing soccer and wants their dad at the soccer game.
right.
And but yeah, I have somebody on a table I need to be taken care of right now. So how many doctors do get pulled? Because look at what you go through, Kim, with phone calls at 3 o'clock in the morning and all that, and you're taking care of your dad, taking care of you, because you still have your physical. You still have to think about money, paying bills, cooking, and all of that. But yet you answer the phone 24 hours a day. And how many doctors like Dr. Manasari, Dr. Phillips, and look at what Dr. Alper goes through. I can imagine being married and having to answer a text message 24 hours a day, but still be with your son or your daughter and be with your family, go on vacations. And there was a doctor, he was on a boat, wasn't he? And he was on a vacation with his wife and the kids, and he's still answering phone calls.
Yes.
And it's like,
yep.
How do you find that balance between being the best CLI fighter, but still being a human being and still wanting a family and still having to take time for myself?
I think that that's a good point, because I truly believe your family should be your first priority, right? You should be your first priority, because you can't give everything to your family if, as we talked about, you're not whole yourself. And so you always want to be your best for others. So that means you have to be the best to yourself first. Now, that being said, that to be I'm just talking about this particular field, okay? To be what we would consider a CLI fighter. CLI fighter, the critical limb ischemia, the most advanced stage where arteries are so blocked. They have rock hard calcium. The pipes have just had gunk building up for years and years and years. And it becomes, just rock hard, right? They talk about the hardening of the arteries in so many cases. It takes a special person that has an entirely different, almost angelic mindset to have the dedication necessary in patience to be able to slowly chisel their way through and to take the time necessary to learn the advanced skills to be able to open up those vessels. Now, for the most part, there's a school of doctors that actually say it's not even worth doing that. You guys are all wasting your time. You should just cut it off and move on and let the patient just start their journey instead of kicking the can forward and delaying the inevitable. There is a serious school of doctors that truly believe this, but I'm all about honoring the patients that will all. I did a survey, and the majority of patients said they would rather have a revolving door of treatments, which some in comments of that poll actually said that they look at it as a tune-up, that they get their teeth cleaned and they get the plaque and the calcium off their teeth twice a year. Why can't they have the same for their arteries? Now, the risks, right, between the two, very different. We get that. But just to educate people, if there are clinicians or physicians watching that are sitting there going, oh my gosh, this is stupid. it's a very real consideration. We need to take the time to understand the patient perspective. And yes, there are serious differences, getting your teeth cleaned and getting the plaque cleaned out versus having a procedure in which you have to create a puncture and go into the artery, and there are risks of perforation, dissections. We talked about poking the beehive, where you poke a clot and then it showers a whole bunch of clot down and trashes the foot. But I think, Douglas, and you can correct me if I'm wrong, at least they want you to try. And there are these doctors. How are they going to try to improve these methods and make them more durable if they don't practice and they don't try? No, they're not durable. We all know that. But what if along the way, a patient's willing to take that risk and say, hey, if amputation is going to be my only option anyway, with a lot of doctors, why not let this doctor at least try and see if there's something they can discover, see if it's possible to maintain my leg open.
Holy cow, that is oh man, holy smokes. That is one of those things. Here's a thought. You know what? I'd rather get another 1,000 miles on my leg than I do understand there are circumstances where it just absolutely has to happen. I do understand that. But how many I'd rather go twice a year and get a procedure done and keep another 1,000 steps on my legs than just because that's what the doctor called my brother that morning and said, if we don't do this bypass, he'll lose his leg. It's like, try it. Just do something. I don't try something. I'd rather do that than go through the insanity of what we hear people go through with the amputation part. Does that make sense? So hell yeah. I mean, heck yeah, beyond the shadow of a doubt. I'd rather doctor at least try to give me another 1,000 steps before just saying it'd be easier than just do it now. Because if I can keep my leg another year, another 2 years, I'd rather do that than do it now, and just because it's easier to do. That's just me. I'm just talking about me right now, okay? So I'd rather you try, and that goes back to that New York article. That's what made me upset about that article, is that it took away a lot of doctors' chances of trying something to get me a little further down the road. Is it just easier to just cut the leg off right now? Let's just move on. That's insanity. That's insanity thinking. If you're not willing to at least try something a little bit different that you may not know, or that let me go to another doctor. Like what happened, I ended up in Houston, and Dr. Z was able to get through everything that he was supposed to get through. The other doctor said, nope, sorry, too bad. Just live with what you live with. And it's like, hello. I drove another 2 hours, and he goes, well, no problem. And 4 days later, he went through. So I'd rather have that than just some guy look at me with a white coat, look at his phone and go, well, we'll schedule you for amputation tomorrow morning, and you'll go home and we'll be done with you.
And I think that situation goes to show that there was a different doctor that, well, it was the only option that he had. At least he tried, right? But and you got to give him credit. At least he tried. He did, but he did what he knew. And you got to give the doctors credit for trying and doing what they know. But sometimes they don't even know what they don't know. They don't go and learn. And this is back to the original conversation. They don't go to the additional conferences to learn something new, because it is a lot of time. They might have their family. They spend a lot of years, learning and growing, and they get to the point where, you know what, I've learned everything that I need to learn. I'm just going to go. It's just a job. If they present with these symptoms, I'm just going to do what I know, and I'm going to go home at 5 o'clock.
You have to change that thinking. You have to change that thinking. I was an LCDC for almost 30 years. Every 2 years, we had to do at least this part of training in this area, that area, this area, and this area. And the reason why, because everything changes. everything grows. Everything grows. So that technology is not today what it was 10 years ago. Technology today is not what it was a year ago. So you have to stay up on that technology because the world's changed. The world changes around us constantly. New technology. I mean, what was the first time you got in a car and you pushed a button and the window went down? Everybody got so excited. Instead of having to crank it down, instead of having to lean over on the passenger side to crank the window down in the Volkswagen, you just pushed the button right next to you and the window went down. I mean, hello. So everything constantly changes. So we have to grow with that. And the doctors need to be able to, is that something that they need to, is that some of the requirement that maybe they do need to set out for them, that every 2 years, maybe they have to take this course or that course.
But also, I think that there is a doctor for everyone, and there is everyone for a doctor. And I think every doctor has, offers incredible value. And one of the things that I presented at the conference is that it doesn't mean you can do everything for everyone. And even one of the doctors said that. It was actually Sean Leiden, a vascular surgeon at Cleveland Clinic, who was there, who said, I'm a vascular surgeon, and I'm the first to actually admit that, you know what, I can't do everything for everyone. Well, maybe I can do something. And while I was in school and maybe in fellowship, I ended up learning how to do something for everyone, but does it mean I'm the best at everything? And he says, absolutely not. So he said, that's where the team effort, comes in at every single facility, where a doctor can say, yes, I could do it, but doesn't mean I should do it. Or is there someone that might have a different set of skills, or maybe more currently practiced in doing a specific procedure? And I'll give you an example. So let's say that aortobifemoral bypass with Sean Leiden, and I'm not saying this is the case, but maybe he has in the past 6 months done a lot more of what we call the minimally invasive procedures with wires and balloons and roto-rooting. And he may have only done 1 or 2 aortobifemoral bypasses. So one comes through the emergency room and presents, and he says, you know what? I haven't really done a lot of those lately. I might be a little rusty. My buddy over here, I'm going to call him in because there's time. It's not quite acute. And I'm going to let him do it because he does at least 2 to 3 of these a week. He's more practiced. It just happens to be that is part of his current patient population and what the luck of the draw of what he's gotten lately. So because he's more practiced right now, I'm going to let him be that firsthand person handling that patient. And I think that needs to be something that needs to be standard practice, that people need to give up the patient, be willing to give up the patient, put aside the ego. It has nothing to do with the fact that you're not a good doctor. You are probably the best of the best doctors, but are you the best of the best at that particular situation with that particular person's presentation of disease? Maybe, maybe not. But it's worth taking a breath, taking a step back, and taking that into consideration, that there might be someone that is more practiced, even more currently practiced in one thing over another.
How often do you see that fight out there right now, though, between the doctors and not wanting to because I wonder what my doctor will think if I ask for a second opinion.
Well, I hear that all the time. And I actually told the doctors, I said, it's what patients want. They want you to tell them to go get a second opinion. But I was at my chairman, Dean, went to this ophthalmology conference, and they had where they were telling doctors, they educated doctors on the power of a second opinion. And you know what the moral of the story of that was? Like, it actually builds trust with that patient. And their studies show that when a doctor tells a patient to go get a second opinion, that patient will never go get a second opinion. They'll always say, "Oh, wow, that means so much to me, doctor. You must be really confident in what you can do. And I like you and I trust you. So I'm just going to go with that same thing and whatever you want to do." But I warn patients, it is the right thing to do for a doctor to say, hey, before any procedure, before anything, always get a second opinion. Learn what's out there. You don't want to have any regrets. I don't know maybe what else might be out there. I don't know if there's a doctor down the street that's in a new research study for a new novel technology that might be the holy grail for your situation. For example, with the deep vein arterialization, what they call the DVA, there was that company called LimFlow, and they were offering this procedure that hijacks a vein into the foot for what we call no option patients that were on deck for amputation. They had nothing else to offer, and hijacking a vein from the ankle to the foot was at least worth trying. But the patients didn't know, and a lot of the doctors didn't know that this was even out there, because the company has the ability to choose which facilities it's going to hold trials in and offer it before they get FDA clearance. And so they don't know, you might not know, but maybe a little extra researcher calling us at the Leg Saver hotline, we might know of a different option that might be available for you to at least consider prior to amputation, or prior to having, let's say, the aortobifemoral bypass, or even an endovascular procedure.
I would love to see research on like an axial bifemoral bypass for over the last 10, 20 years, where it was and where it is today and how often it's done and what it's like for those people 10 years after having it done or 20 years after having it done, in the research on how often it has to be changed out or the conditions that it creates. So there is a lot of research that still needs to be done out there in a lot of areas.
And you know what, the only research I've seen on the axillary bifemoral bypass and its durability, I've seen it's up to 7 years, but there's a very high mortality rate. Especially when you read the earlier studies, there's less of a mortality rate in the early days of having it. I mean, later on in recent years that I've seen, but I've never seen it as a long-term, durable option. I mean, more than 7 years. I haven't seen it. I don't know if it exists. I would love for patients to come forward and say, hey, I am doing absolutely fantastic. I've never had any organ trouble. I've never had any heart trouble with this, graft actually, pulling blood, away from the heart, stressing the heart a little bit. The cardiologist told me just a couple weeks ago that he knows these things, these axillary bifemoral bypasses actually stress the heart, which is why he can't believe that vascular surgeons in his hospital in particular, I won't name names, he can't believe that they literally resort to it in so many cases sooner rather than later, because they don't realize that there are so many risks, with it, other than, okay, let's just restore blood flow and not think of anything else. And they won't take time to learn maybe a different option. And it's interesting because I've asked a couple of surgeons about this, and they say, yeah, well, we've done these, but it's so rarely done before. And we really try to exhaust every other effort possible before even putting a patient through this axillary bifemoral bypass. We consider it palliative care, last resort, Hail Mary, nothing else can be done. Get your affairs in order. And I know that that's how they really, consider it, especially in the UK when they do it.
Well, unfortunately, the first thing I did after I had mine was Google. And it was like, well, I'll be
Google.
dead in 5 years, so I might as well. And it was that thought. I went ahead and hired a lawyer, got all my affairs in order, and I made my will. I did all of that. So, if you look up Google, it was like, well, survival rate's 2 to 5 years, and it was like, well, heck, I'm going to be gone anyway. So it's like,
and it's interesting.
Everything I've been through now with my axial, is it from the fact that it got blocked up? And I'm not a doctor. No, I'm just I'm just a country boy out here in the country, but
Yeah.
I really believe that my graft has caused all the issues that I have. That's just
Right.
me.
But every time we've been to the doctor, and I've been to a lot of procedures, one of the things for those watching that I do with the Global PAD Association is I will show up to appointments with patients and help to facilitate the conversation, ask questions, and take notes, throughout. So I've been to a lot of appointments with Douglas. And what I heard over and over again from different vascular surgeons and cardiothoracic surgeons, handling his case with his heart and his PAD and his aortoiliac disease, is that no, there's no way that this graft's causing any of the problems, with your heart or any other organ. And I said, well, how do you know it doesn't? And they said, well, I've never seen it. I said, well, do these patients come back to you? Well, I don't know. I never really thought about that. And I said, well, are there any studies on it? And they said, no. And so I said, okay, well, that's probably why there's no evidence. And they said, yeah, we're usually, there has to be evidence. And I said, well, how is there going to be evidence for you to practice upon if no one studies it? You need to think beyond, because medicine is a practice, and you, Douglas, might be the first one to actually bring it to their attention. There are so many people that suffer out there and never say a thing. So many people that suffer and die and never even speak a word.
The point about that is this: they're not the ones sitting in the truck. When I sit in my brother's 4 hours away, if I sit in the truck about 35, 40, 45 minutes, I have to get out of the truck because my graft is poking me in the leg. The more it pokes me, the more I have trouble upstairs. Does that make sense?
Yep.
So I'm the one living with it. And how many of our patients are the ones living with that? And how often have we heard doctors say, I never thought about that. I never thought about it that way. So I have this tube in me that is a 4x4 sitting on my groin and my right leg 24 hours a day. And if I sit in I can't kayak, I can't bicycle now, because every time I pull my right leg up, it pokes me in the groin. I hate to say that, but it pokes me in the groin area. And it's like, Doc, I don't, how do you want me to explain that? So it's that part about, I think that's where we're all learning today, where it's hard getting the team together, all the team together, but it is coming together. It's just a slow progress of just one step at a time in it, where all of us are starting to get to where people are starting to change and think about each other. Because how many times in we group we've had doctors on our program, and I remember Chicago, that one doctor going, I never thought about it that way.
Yeah.
Even Dr. Phillips said that one time. He said, I was sitting, I had somebody open on the table, and he goes, I didn't realize I actually have this individual's life in my hands right now.
Yep.
And he said, I wouldn't have thought about that if I hadn't been a part of this group. And we're all starting to share together and learn together and grow together. And it's a process of learning for all of us, isn't it?
Yeah, it's true. And I think it's about time when you go, on our padstories.com, I think it would be interesting for you to share in maybe your, and instead of just a general confessions of a walkaholic, maybe do a general written blog of living with an axillary bifemoral bypass. I think that would be a very powerful piece, and it would be something that if people were searching online, I think that would be the first one that I've seen out there, and it could be a great resource for so many out there to take a moment and step back before, for doctors, before doing them, understanding the impact that they have, but then also for patients, we could include some critical questions to ask. We had Karen, and I know she doesn't mind me using her name, and she was, we just dealt with this, as you know, just in the past week or so, where she was offered, she presented at the hospital, an HMO here in the San Francisco Bay Area, presented with a blocked aorta clear above the renal arteries, meaning above the kidneys. So the aorta was blocked pretty high up. And we had this, we dealt with this, right, Douglas, 3 years before, and you were one in the saving graces for her to learn about. They were just going to do the axillary bypass from the shoulder to the groin, to bypass the entire aorta and even her kidneys 3 years ago when she presented with these clots in her aorta. So they immediately wanted to go to the axillary. They may have been able to do an aortobifemoral bypass if it was below, if the blockage was below the kidneys. But once it's above, you need to think of possibly a thoracic, which is a 10-hour procedure. Now that I give some consideration to, and I almost gave it some consideration in this case, in this second go round with her just last week, because if you are healthy enough, if you can withstand that procedure, then that 10-hour procedure, a thoracic bypass, is very durable, like 91% durability up to 15 years. And then if that fails, you still have the contingency of having the axillary bifemoral, which could give you another 2 to 5 years, right? Or maybe by that time, there's some new innovation that might be able to give them something, you know, different than that with even more long-term durability. But in the case 3 years ago, they said, we're just going to do the axillary. And the axillary, the reason they want to go to that, and especially if someone's not a really good, really healthy individual and it's a pretty bad blockage in there and it's too risky and they chance, and it might be pretty hard tire rubber inside this aorta or really rock hard calcium, there's a serious chance that when they take that wire up there in a minimally invasive way, that they deflect, right, and can puncture that artery. They can perforate, and the risk of death is just way too high. Not even worth it. And with an axillary, it's actually a pretty quick and easy, I won't say easy, but it's a quicker procedure, and it's more durable, let's say, sometimes than just going in with a wire in certain cases, and it's less risk, let's just say, than doing it with a wire. But in Karen's case, we saw an opportunity to get a second opinion outside the HMO, and the doctor was able to use that advanced imaging I talked about earlier, the intravascular ultrasound or IVUS, as well as Avenger with an additional camera on it when they did a little roto-rooting to pull out some of that extra plaque. That was durable for her. It worked for 3 years until she forgot to take her medication a couple days. And for her, she's hypercoagulable. So the moment she stopped, within 12 hours, her body was just throwing clots. So she blocked right back up again, went back into the emergency room. And the first thing the doctor wants to do again in this HMO is wants to do the axillary bypass. She's only 55 years old. And granted, it is an option. It is an option. And what we found out why they presented it as an option is because they thought it would be a lot quicker for her, right? And it would be more durable. So they're looking to say, okay, if we do the axillary, she'll at least get 2 to 5, possibly up to 7 out of it. And then we'll worry about what is going to happen after it ultimately fails. But at least we're going to get them further down the road. Versus an endovascular procedure, the minimally invasive with the wires and balloons, a little bit more risk in some senses if you don't really understand the morphology of the plaque, the type of plaque, and the consistency and the material in there. As with Karen, it lasted 3 years because she forgot to take her medication. Might have lasted a lot longer. But, and then, so that was the reason I wanted to do it, and I understood it. We ultimately then got him to, we had to get the president involved and the senior vice president, because this doctor was all about, well, he knows it all. It was his standard. He felt for his hospital, their situation, her presentation in that moment to just get her fixed and out of there. That's what, and keep her out as long as they could. That's what he was trying to do. As we pushed, then they started considering the thoracic. And it wouldn't have been my first choice, but certainly it was to me a more durable choice than the axillary if she was healthy enough. But I still wanted them to try an endovascular first approach. At the very least, take a catheter and direct it right into that aorta and melt that, see if they can melt the clot in what they call a TPA. So it's a catheter delivery of clot busting drugs direct to that. He was like, well, that's an option, but I don't think that that's a good option because it's so risky and they could throw some clot down into the foot and then we'd have to go and retrieve that clot. And, that stuff just isn't as durable. And look at this thoracic and it lasts longer. And I'm like, I'll give you that. I'll give you the fact that it'll last 15 years. I'll give you that. But now she's developing wounds from sitting in the hospital for 4 days. She's developing wounds. They're getting infected, bed sores. And so now the thoracic is becoming less and less of a preferred method by the doctor because he's like, oh, shoot, there are already these infections that are at the skin. So maybe not. Now let's go back to the axillary. And I said, no. Why can't we consider the TPA? You don't have to go 0 to hero. I know it's risky because you can end up having a major bleed, but let's just go in and do it lightly. And let's just see if the clots will dissipate at all, even some of them. And then if they dissipate, why can't you go up there with your additional imaging and suck that clot out? Why not try? And every excuse in the world and whatever. And once I let him, talk till he was blue in the face about every risk, every con, I don't give medical advice. I turned to the family and I said, let me just talk to the family. And I said, okay, you understand your options. I know your preference because, and I said, doctor, you have to understand that she was told the same thing here 3 years ago that we needed to do this axillary. And then she was able, understandably, to go outside, find a different doctor who specializes in this. And he was able to open it up in a minimally invasive way. So now she's wondering, like, why? I don't understand if it worked back then, why can't we try? Why can't we try it now? Why will you not try? Is it just that you're so good at these axillaries and this is what you're practiced at and you've had bad experiences because maybe it wasn't quite your skill set to do the endovascular? It might have been. When doctors poo-poo something, you always got to ask yourself, well, is it that it's really that bad? Or maybe they're just not that good at that and they're better at something else. And good on them for knowing what they're good at and not offering you what they're not. Last thing you want is someone doing a procedure that they're not good at just because they think it probably is what they should be doing. In those situations, what we ask is that they give up the patient to someone else, right? And it ultimately ended up to work out in our favor that because she didn't really want the axillary, she really wanted to try and give it the best shot to do it minimally invasive, that he said, well, suddenly I'm not available. I got to do procedures. And we discovered that he loves doing surgical procedures. Like that's his passion and good on him. And I bet he's darn good at it. So he ended up, because he had procedures the next few days, he said, well, so I'm not going to be doing my rounds in the hospital. So I have to pass you over. I have to pass you over to this other vascular surgeon that is going to become your supervising physician from here on out, because if you don't want surgery, then I'm just not available. And he comes in and says, yeah, this will be great. Oh, this is awesome. This is going to be successful. No problem. We're going to go in. We're going to take a catheter. We're going to put in a little bit of, this drug. We're going to go a little at a time so we don't risk a bleed out. I'm going to stay watching you. And he went in, and within hours, Douglas, within hours, she started to feel her toe. And overnight, they were able to clear, get this, 70% of the clot. they were able to clear. He
Yep.
went in the next day, got most of it clear, and he went in and was able to take a thrombectomy device and just suction out the remaining clot and add in another stent. And she's, I think, either going home today, she might be on her way home today, or she might tomorrow, which if she had those bypasses, she would still be in the hospital with those bed sores and nursing those and those getting worse for the next, week, maybe 2 weeks.
But we
And
also had one in Florida with the same thing. If you remember, they were going to do an aorta bifemoral or an axial, and she said no. You shared with her, and she said no, and she got a second opinion. And 4 days later, that doctor went in and saved her leg also.
right. And so it's not to say then you have a case like our friend Valerie in the group, and she came on and she shared her story recently with us. So I can reiterate what she had said. Is she did have her doctors had said that she needed this major aortobifemoral bypass. She was still young, and they 20 to 30 years and possibly even longer, especially if you adhere to your lifestyle modifications and medicines as prescribed, and a regimented walking program. But it's not, most of the time it's not frontline treatment. And in Valerie's case, she really didn't want a cut, the frontline treatment as being a cut, clear down her belly. And, she was still young. She wanted to wear a swimsuit and, that kind of thing. And while she was willing to do it to save her legs, she said, you know what? I'd like to just see if we can prevent it. Even if I have to have a little bit of a revolving door of treatments here and have to have a little roto rooting done every couple of years, it's not a big deal for me. I would rather have that than have to have a really long recovery, be off my feet for a long time, not be able to work. At least with the endo, I can get back to work. I can get back to walking right away. And I can at least try to see if we can extend this, longer. But she went through 3 of these procedures, and it turns out that her vessels just were not amenable to endovascular. They just weren't. And no matter what anticoagulants or combination she was on, she was just going to clot right back up. It didn't even matter. Just right in the areas, she was just generating clots. So she ended up, after about a year of a fight with multiple trips to the emergency endovascular procedures. And from the beginning, they did want to do the aortobifemoral bypass. She finally ended up having it. And some doctors might say, well, see, she should have just had that done first. But sometimes, because we're finding in most of our cases with our patients, when we say, hey, let's wait on the bypass and do these other things first, an endovascular approach first, it's actually worked. It's actually worked. We've been able to prevent a big bypass and a big recovery and so much time off their feet and so much time off work. With PAD, it's so important to get on your feet as quickly as possible to keep that blood flowing, right? So that's why I do like to, at least if it's medically appropriate, see if someone with an advanced set of skills, not just anyone. You don't want someone that does 18 cases a day. That's not a good number. That means they're just trying to push people through. We consider those a mill, right? I know some cath labs have 2 in a building, and the doctor's just going back and forth and back and forth and back and forth. And sometimes it's not even the doctor doing the cases. It's even just their side tech that's doing most of the case, and who has a philosophy that's like, okay, if it's not done in 20 minutes, move them on out, give up on them. You don't want that. You really want someone, if you are going to go for any procedure, you want someone who has a high volume, not too high a volume of those cases, but not just a high volume of cases, but high volume of successful cases, right? You want to understand, what are their outcomes? What case like mine ended up with a really positive result? And tell me that story. What is that person's life like right now? How long did it last, or is it lasting? Are they up to 10 years, 20 years? Woohoo, that would be great.
Yes.
With endovascular, we have discovered And I think by all the different studies that are out there, where some of them are saying endovascular doesn't work, endovascular is not as good as bypass, or, bypass isn't good as endovascular. I mean, a lot of that, what I've learned, it's dependent upon a doctor's skill set and the doctor adopting a more advanced technique, especially when it comes to endovascular. There are still a lot of doctors that, don't take on the philosophy of a less is more approach. No need for zero to hero in that endo approach. Just give me that much more blood flow, doc, to give me that much relief, or that much more blood flow, enough to heal that foot. Now, in some cases, if the wound's really bad, like really bad, and they need a lot of blood flow and fast, there is a really good school of thought that says a bypass is, and if that, at least to just get that blood flow flooding down there to heal that wound, it doesn't mean that it's going to last a long time. Who knows? But it doesn't mean that you don't have an endovascular option in the future. It's just that right now you need to just flood that foot with lots of blood flow as much as we can get there. And sometimes it is an option. Sometimes it is the better option, even if endovascular hasn't been performed. So there are a lot of considerations, but that's why you need multiple. That's why it's all good to have a patient like me that's been in these procedures before, that is on the front lines with so many different patients, to be able to say, let's map out your scenario. Let's look at your presentation of disease. Let's look at the options that your doctor is presenting to you and why. And let's see if there are other doctors in your area, as long as you don't have an acute situation with your life or limb on the line in that moment, right? To take the time, be able to sort out the different options and sort out the skill set and make sure that you do option for you. Does it mean there's going to be a complication? Something can always go wrong, but at least you need to take the time to understand all of the options available so you can make an informed decision.
So let's give the doctors a chance to breathe. And we also need to remember, let's when we walk out of that doctor's office, we have to become a responsible member of that team and take responsibility as patients in our care. That means walking, eating, smoking, drinking, whatever it is. We have to also take responsibility for our health care also. In changing the lifestyle that we need to change, so that we work as a part of the team. Because if I just go to the doctor and expect him to just fix everything, it's not going to work. I can't go home and just lay on the couch and eat and drink and smoke and do whatever and do nothing. I have to take responsibility for my part in this also.
That's a really, Douglas, that's an excellent point, because that was also brought up at the conference. And what was frustrating for me, and not to say I'm the Holy Grail, I'm certainly not the Holy Grail. Do we have all the answers? No. Option. One of the doctors got up there from Stanford and she was saying it's frustration, the fact that patients are not adhering to any lifestyle modifications. They're not stopping smoking. They're not eating better. And no matter what they do, they just don't, adhere to these things. And I'm sitting here saying, I'm here. I'm willing to help. Why will you not give up the patient to me? You don't have to give up the patient. Why not invite me? And I'm saying me, why not invite us as the Global PAD Association? Why not invite the Global PAD Association to be your advocacy partner, doctor, to help support your patients in adhering to their lifestyle modifications? And it works, right, Douglas? Are you perfect? No. Do you have cheatery moments? Yes. Yeah. But how much better are you we're not dietitians. We do have dietitians on standby. We do have functional medicine practitioners and supplement experts on standby. And you're our resident smoking cessation expert, being certified in the state of Texas, for addiction, to help people with that. But how much better is it with our support and our network and our group in helping you and others to adhere to these lifestyle modifications and to get motivated to walk?
I hear it every day because we put something out there, somebody put something out there about certain steps they took today, or they took this different a walk. It got somebody else willing to get out. The eating thing, I mean, I can't go shopping today without looking at the back of the box, because I used to just look at the front pictures. Fruit Loops looks wonderful. It just looks wonderful. But when you turn the box around, it's like, oh, wait a minute. That's not good for me. So I'm learning how to eat and change that eating behavior. Food tastes different with no salt on it today. It really does. But I know that salt is not going straight to my legs now, so that I can walk that extra 1,000 steps that I want to walk today. The smoking is the same thing that we heard about the drinking from one doctor about the drinking, and that just depends. You can't drink a 12-pack a day. No, we got to stop that. But the eating and the walking, and how many people, I'll say it. There are some people, and I'm guilty. We need to get off the couch. I know getting off the couch. I know this scientifically for a fact. The more I walk, the better I am. The more I eat better, the better I am. The more I stop smoking, the better I am. The more I do the things that are healthy for me today, mentally and physically, the better I am, which helps the doctor, doesn't it? That's that cycle. If he does his part, I have to do my part. I can't expect him to do his part and then me go home. Or like that one doctor said that time, he walked to the window. He took care of this patient. He said, I'm going to fix this. He walked to the window and saw the patient walking across the parking lot, lighting a cigarette. And he said, I stood there and thought to myself, what am I doing? Because, and that's where it takes all of us working together. We can't it's not going to be one. It's going to take all of us. It's going to take defense, offense, a quarterback, and a wide receiver. It's going to take a linebacker and a free safety. It takes all of us to win this game, to save life and limb. And I have to be an integral part of that. I have to become that advocate for myself that I need to be today. I have to be able to look at a doctor and go, wait a minute. I remember being in the hospital a couple of months ago, and that doctor walked in. He goes, I had to look your condition up. I didn't know what it was. I remember looking at him and going, well, guess what? You don't need to be in this room then. So I have to become that advocate where I say to the doctor, turn your phone off, put your phone up a minute and answer this question for me. Because I'm sitting in front of you right now. I was at a doctor, and 30 minutes sitting in that room, 20 of it, he was on his phone, 5 minutes on the computer, and he never even touched me. So it's like, I have to say, wait a minute, doc, hold on. Did you check my feet? Can you check this? Can you feel this? I have to be kind of, not confrontational, but I have to be assertive. I have to learn to be assertive as an advocate for myself, and advocating for my care, and saying, well, I'm going to get a second opinion because that just doesn't sound right. Make sense?
Yep.
So I have to become the best advocate. I have to do my part. It's just really that easy. I can't sit on the couch. I can't sit in my recliner and say, I'm not making progress. Well, I'm not going to make progress if I'm sitting on the couch and in the recliner and not at least walking to the driveway. I live in a 29-foot travel trailer. I can walk from one end of the travel trailer watching TV and build collaterals. It takes 11 steps to go from one end to the other end. If I'm willing to do that, well, then I'm saving a life and limb, and that's mine. But if I just sit here in front of the TV, I'm not doing the work that I need to be doing. Take paper plates, put them on the floor, put your feet on the paper plates, and move your feet back and forth. You're doing something. Grab a can of green beans, sit on the end of the couch. Can of green beans is no more than 5 pounds, but you can work out with those green bean cans. You're sitting there watching TV at the same time, you know? So you're doing something. We have to become that integral part of the recovery team for ourselves. That is our responsibility, mine and mine alone. No, there's my soapbox.
I love it. And I think that that's a good place to end, because I don't want that really powerful message to get lost in the middle of this. And so I would rather, especially for those that might fast forward through, I want them to hear exactly what you had to say, because it was a powerful way to end this really long but very impactful conversation that went in quite a few different directions. But I've loved having the conversation with you, Douglas. It was really insightful. I know I had my moments on the soapbox as well, but overall, I think that we all need to be better partners in not only our own care, but in the care of those around us. So, and we all have the best heart, the best mind, the best intentions to do so.
Yep, we do. Even the doctors, all of us do. We got to play fair.